implies bad prognosis. And we get a whole body technician bone scan as well. And then we assess the liver quality and quantity. So, of course, CTP MELD if there is cirrhosis, HVPG, and if it's less than 10, then it's not 10%, 10 millimeters of mercury. Then it is a good risk resection or a good risk patient for resection. ICG clearance less than 10% is also good. That means the liver is clearing most of the ICG. And volumetry, if there is 50% remnant, that's a good risk patient. But if there is a normal liver, which is unusual in HCC, it's a normal liver without any fat, without any cholestasis, and of course no cirrhosis, then even 30 or 35% is acceptable. Now, these are standard Ucsf criteria propounded by about 20 years ago by Yao et al. From San Francisco. And it basically means less than 6.5 centimeter single lesion or up to 3 lesions, each less than equal to 4.5 with total diameter of less than 8 and absence of macrovascular or extrahepatic spread. And these kind of patients, if they are transplanted, give a 1 in 5 year survival of 90/72%. Now, let's look at the kinds of surgery possible for HCC. One is a primary liver transplant. The second one is a resection followed by a salvage transplant for recurrence. And the third is resection as a primary treatment. Now, liver transplant for HCC. If there is decompensated cirrhosis and early HCC, or there is child's A or B with more than 2 centimeter lesion or multiple lesions, they are bad risk for resection and a straightforward selection for transplant. Then the controversy arises when the lesion is more than 2 centimeter and is a good risk for resection. Then, of course, expanded criteria are controversial. And then the most expanded criteria when patient with HCC has vascular invasion of Pvtt, then if you think of transplant, that's even more controversial. We've actually done that too, and I'll show you how. Now, why extend beyond conventional Milan or UCSF? Because the conventional criteria were made in the deceased donor setting, and they are not really valid for living donor liver transplantation. And if you do LD-LT for beyond criteria HCC, there is no competition for donor liver. There are less dropouts due to disease progression, and there is survival advantage due to a better graft. And obviously, the conventional Milan criteria based on size and number are very restrictive, and they exclude many patients who can benefit from transplant. This is a diagram which shows basically the size, number, and vascular invasion issue. And you can actually see that in a patient who has macrovascular or microvascular invasion and has 8 centimeter tumor and may have up to 7 tumors, still has a 30% chance of long-term survival. So that means that all patients with large size and number and vascular invasion do not do badly. So we have to understand the biology of these tumors. What is our policy? We transplant all HCC in cirrhosis unless they are less than 2 centimeter single lesion, without extrahepatic disease, as long as there's no medical contraindication to transplantation. And the major vessels, that's portal veins and hepatic veins and IVC, should be free of tumor. So we take all comers irrespective of tumor size and number. And we've actually published this. And we published this very recently, our entire series based on these criteria. And you can look at the total series here. 2,348 living donor liver transplants, of whom 451 had HCC, 46 had a different protocol because they had portal vein tumor thrombosis, and 405 did not have portal vein tumor thrombosis, and approximately 18% of all liver transplants. And these are the ones we're going to look at. And as you can see, half and half within and outside Milan, and about 60% and 40% within and outside of UCSF. This is the overall and recurrence-free survival. And we have 10-year survivals of around 65% among these patients. And this is all comers, and an overall survival of around 58% at 10 years. Obviously, if there is macrovascular invasion, they do worse. If there is microvascular invasion, they do worse. And if you treat recurrent tumors, they do worse. We also looked at the poor prognostic factors and people who have a higher AFP or who are beyond UCSF, who have FDG avid tumor, they do worse. Now, a whole lot of people have proposed expanded criteria for deceased donor transplantation. These are the lists. And basically, you're able to get reasonable 50 to 70% long-term survival with expanded criteria in DDLT. And similarly in LDLT, based on the various expanded criteria, Asan criteria, Kyoto criteria, and so on, and also Medanta criteria, which I just showed you, we are able to get anywhere from 56 to 87% 5-year survival. And these all expanded criteria look at biology. For example, the Kyoto criteria look at Pvt2 or DCP of less than 400. And most people look at alpha-fetoprotein. Now, these are the specific ones that look at biology. The Kyoto criteria, they look at DCP. The Hangzhou criteria look at AFP and tumor grade, and Kyushu criteria and Toronto criteria. Toronto guys do a biopsy for every HCC patient, and then they look at tumor differentiation, although we all know that the differentiation may vary between different parts of the tumor. Now the morphological criteria of the size and number are kind of old-fashioned, and everybody's into biological criteria, and that tells us the biology of the tumor, and that seems to govern the prognosis. And so the various parameters used for biological criteria are alpha-fetoprotein, Pvt2, FDG18 avidity, the ability to downstage them to within Milan or UCSF, waiting period test, which means that they don't go beyond transplantability during a waiting period of 3 to 6 months, and NLR, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and histology. So these are what everybody looks at now. This is just to show that PET negative tumors do better than PET positive tumors, and those with an NPF of 0 do better than NPF equal to 1. This is again based on the platelet lymphocyte score. Less than 120 is obviously better than more than 120. So if you go according to the Hangzhou criteria, where they look at the PLR, then those guys who may have size and number beyond Milan, but they have a PLR of less than 20, do as well as the Milan group. Train score is another score that has been described by Jean Leroux, and we've actually published 3 papers together on this, and it basically includes time radiology, TR, AFP, inflammatory markers, that's NLR. So it's a train score, and again, it is based on not just the waiting period and radiology, but also biological scores. I'm not going to go in absolute details of these. I just want to give you an idea of how biological criteria work better nowadays. So, in summary, LDLT for HCC with expanded criteria, one can get 80% long-term survival without recurrence within 3 to 5 years, 70 to 80% overall survival. At Medanta, we've already shown you our results. And it seems that living donor liver transplant may be the best curative strategy, even for patients beyond UCS. Now, this is a consensus conference which we had in Rotterdam a couple of years ago, and we published this. So this is a world consensus conference under the aegis of ILTS, the International Liver Transplant Society. And what we decided there was that for LDLT, living donor liver transplant, the criteria should be different from DDLT. With good biology, with validated selection criteria based on alpha-fetoprotein, FDG avidity, DCP, response to local regional therapy, criteria may exceed UCSF size and number criteria, provided there's no extrahepatic disease or macrovascular invasion. And we published this last year in Transplantation. And because it's living donor liver transplantation, double equipoise must be maintained. There should be a minimum acceptable recipient survival of overall 60% at 5 years, and minimum donor risk, which means zero mortality for the donor. Now, downstaging of advanced HCC is obviously a concept which has been propagated again by Francis Yao. And don't bother reading through this whole thing, but basically it says that if you downgrade HCCs beyond T2 or beyond UCSF to within UCSF, they do as well as the original de novo UCSF or T2 lesions. Now, let's look at patients who have portal vein tumor thrombus, PVTT. The median survival of untreated PVTT is 3.7 months. But we and others have shown that not all these patients should be written off. This is just a reminder of how we grade the portal vein tumor thrombus, VP4, VP3, VP2, and 1. And there has been some publications from Korea and our group which says that patients with major PVTT can achieve long-term survival, 63 and 45% 1 and 3 year survival among 11 patients who had portal vein tumor thrombus and they went ahead with a liver transplant. Another series from Asan Medical Center, Seoul, where they did 17 patients of HCC with major vascular invasion after TACE and radiotherapy, and they achieved a 3-year DFS and OS of around 60%. This is our series of patients with PVTT and downstaging prior to liver transplantation. This is the largest series in the world. And let's look at these 55 patients, 25 of whom were downstaged, and 30 were transplanted without downstaging because they had early portal vein tumor thrombus like segmental veins. This is the downstaging protocol. They are assessed in the usual fashion. Then they undergo stereotactic body radiation therapy with CyberKnife or with the ABC method, for which, and then they also have a tear. So SBRT and tear, usually SBRT and tear. Sometimes TACE is done when only segmental veins are involved and there is no main portal vein tumor thrombus. So how we do this is we do tear 1 where we assess shunts. Then we put fiducials for SPRT. Then we do the SPRT over 5 sessions or so. And then we do the tear 2, which is actual injection of the radioisotope. We do response evaluation after they've had this therapy after 6, 8, and 10 weeks. So once they've had the tear and SPRT both, then we do response evaluation at 6, 8, 10 weeks. And if there is no FDG enhancement or contrast enhancement in the tumor thrombus, then we take that as a response. And if there's a partial response, then we probably wait another 2 to 4 weeks and or repeat SPRT. And after there is complete response in the portal vein tumor thrombus, we do living donor liver transplantation. And this is the survival. These are actual figures, and we've actually had 57% long-term survival, 82, 57, and 57% long-term survival. If you compare it with the alternative therapies, which means palliative RT with or without sorafenib, they do pretty pathetically, and there is a huge advantage in terms of a transplant benefit at 36 months of around 23 months. If you do this, that means downstage, PVTT, and then LDLT, compared with alternative treatments, which are palliative, you get a huge survival advantage, transplant benefit rather, at 36 months of 23 months. And the transplant benefit at 5 years is also around 20, it's higher actually, 32 months. And then what about resection followed by transplant? The relevant issues are results of salvage transplant versus primary transplant, the proportion of patients with recurrence who can be transplanted, and eventual outcome of HCC patients on an intention to treat basis. That means you start out with 100 patients, some you do primary transplant, some you do resection followed by transplant, and how do those fare? So our salvage experience early on, we looked at these 258 transplants, confirmed on liver biopsy 249, total liver resections 274, resections for cirrhotic HCC 103, all pre and at least 2 years post follow-up data available on 52, 50 were transplantable. So 50 were transplantable who then actually underwent resection, and 25 of these 50 recurred at 3 to 28 months, and 12 of these were transplantable when they recurred. And 7 14 of the LRT group and 28% of the total recurrence group ultimately underwent salvage transplantation. So you can see that only 7 of these patients eventually underwent transplant out of the 50 that were transplanted. And 4 were resected elsewhere, and we also did a living donor transplant on them. And all 11 were well at that time, 2 and 39 months after salvage transplant. So this shows 2 things. Only about 14% of the original group were eventually suitable for salvage transplant, and salvage transplant patients do as well as primary transplants in terms of surgical success. So operative mortality of both primary and salvage are similar. And this is another series by Belghiti, where the survival after primary versus resection and salvage was 64 and 56 and 60 and 32 respectively. So the long-term survival was worse with resection following resection and salvage transplantation. And 65% of them recurred in a mean of 31 months, and only 28% were transplantable. So all this means that 1/5 to 1/4 of the original cohort who are suitable for transplant to undergo resection will eventually be suitable for salvage if they have recurrence. So resection alone seems to be inferior policy, especially if you're relying on later salvage transplant. So the summary is operative mortality in salvage is similar to primary. Recurrences after resection of HCC cirrhosis usually occur within 3 years, and recurrence is more advanced than the primary tumor usually. So if the primary started out to be within Milan, the recurrence may be beyond UCSF. Less than a third of those with recurrence will actually undergo SLT. Third is also, it's pretty high estimate, usually around 20%. And on an intention to treat basis, disease-free survival after SLT is inferior to primary transplantation because not all of them are suitable for salvage transplant. Now, resection as primary transplant. Now, resection or transplant, if you have a tumor which is, let's say, 3 to 5 centimeters, single tumor, child's A patient, 3 to 5 centimeters, should they have resection or transplant? A lot of people who do resection, I've done resection many times, but then it depends on what the patient wants, their finances, the availability of donors, and so on. But let's look at this paper, which was done by one of my colleagues, Prashant Bangi, along with his French colleagues at the time that he was there. And they basically found that on an intention to treat strategy, the patients who had transplantation, and this is transplant patients, and this is resection patients, their early survivals were similar, like 2 to 3 year survival are similar, but 5 to 10 year survivals were much better with transplantation on lesions, single solitary lesion less than 5 centimeters. And resection and recurrence-free survivals were also similarly inferior in resection. In fact, majority of them recurred. In terms of smaller lesions, less than 3 centimeters, there was no difference in overall survival. But I think the recurrence-free survival again scored in the transplanted patients scored over resection patients in recurrence-free survival long-term. Our experience with liver resection, these 10-year period, 152 liver resections, and again, recurrence-free survival at 3 years is less than 50%. The majority of them recur within 3 years. So to conclude, liver transplant is the best option for cirrhotic HCC within UCSF, no doubt, no controversy. Living donor liver transplant is probably the best available treatment for advanced HCC with cirrhosis without extrahepatic spread or vascular invasion, irrespective of size and number. Early HCC, liver transplant is better recurrence-free survival on an intention to treat basis than resection alone or with salvage transplantation. And salvage transplant results are the same in terms of technical success, but long-term they are inferior because basically salvage is done on tumors which are more advanced compared to primary transplants. And resection for non-cirrhotic HCC, insignificant portal hypertension, unfavorable logistics for transplant, sure. If there is no cirrhosis, do a resection. If there is child's A cirrhosis and logistics are not good, do a resection. And a lot of the cases you will get away, half the cases, but the other half will recover. Now, morphological, biological, and molecular biomarkers together should be used to select patients with HCC beyond the criteria, the conventional criteria for liver transplant, because conventional size and number criteria need to be buried, no longer relevant. Only the size and number is no longer relevant. There is a strong association of alpha fetoprotein, Pvt2, FDG activity, NLR, and histology with the outcome of advanced HCC after LT, and there should be used to select among the advanced patients as to who should be transplanted. And downstaging of advanced tumors is beneficial and should be done. And selected patients of Pvtt derive benefit from transplantation after downstaging with local regional therapy. And of course, we all know that molecular biomarkers need to be defined for precise prognostication, and there's not that many that are clinically used currently. Thank you very much.
Thank you, Dr. Swain. This is Hemant Malhotra from Jaipur. Do we have time for any questions, Sachin, or should we move on?
Actually, we are running quite late, and
Okay,
but we really thank Dr. Swain for an excellent thing, and it was really an eye-opener. And HCC is one tumor where we require, multimodality treatment and interaction with other colleagues a lot. As as we compare with other cancers, HCC is the most demanding and challenging cancers, I feel, in this regard.
I completely agree with Sachin. We must have a multidisciplinary tumor board whenever a new patient of HCC is seen at the center. And I think we've heard from the number one man in the country about the state of art of
Sir, in the world.
In the world, yes. Yeah. Like Dr. Swain's data is really.
You're embarrassing me now.
No, sir. You are dawn of liver transplant, sir. We really admire you for that.
Yeah, I agree with that. So can we move on now, Sachin?
Thanks very much.
One question I wanted.
Sure.
Dr. Swain, just a quick question. Do you use any adjuvant strategies in your center after liver transplant or resections?
No, we don't. Okay. We don't use any adjuvant therapy. We only use, multi-kinase inhibitors for recurrences after either surgery when transplant can't be done or recurrences after transplant.
Thank you.
Okay, thank you. We'll move on. Thank you, Dr. Swain, again for a great talk.
Thank you so much.
So I'd like to invite Dr. Arun Gupta. Dr. Arun Gupta is Chief of Department of Interventional Radiology at Sir Gangaram Hospital in New Delhi. And Dr. Arun Gupta is going to talk to us on loco-regional therapies for HCC, and he'll focus on ablation and arterially directed therapies. So Dr. Arun, the screen is yours.
Thank you, Dr. Sachin, Dr. Hemant. I just share my screen.
Please go ahead, sir.
Yeah. So I'm going to discuss about the local regional therapies. What's their role in the overall management of HCC? So I think I'll skip few of these slides. These have been discussed. So as we all know that we try to follow the Bclc classification. Of course, many times we ignore it according to the patient's requirement, size, location, but still it's a backbone of our treatment planning because it gives the information about the what treatment we have to offer to a particular patient. It includes the performance score, child score, tumor size, multiple tumors, vascular invasion, and extrahepatic disease also. So again, I'm going to skip this. We all know that early stage, our aim is to cure it in form of ablative therapies, and for later, the intermediate stage, the chemoembolization, as well as the role of transarterial radiumbalation. So directly coming to the therapies, these local regional therapies, the aim is to buy time for the surgery or for the transplant, or to downstage, as we have seen with Dr. Sain. He has used TEAR for downstaging the patient for liver transplant. And also, even if we are not thinking of curative intent, it basically aim is to prolong the survival and improve quality of life. And especially in patients where the transplant or surgery is not feasible because of the donor limitation. So coming to the what therapies the intervention radiology offers, we can divide into the ablative therapies and the transarterial therapies. Ablative therapies can be of chemical, ethanol, and acetic acid. Thermal can be radiofrequency ablation, microwave ablation, irreversible electroporation, cryoablation, and hypo. Transarterial therapies includes conventional TACE, drug-eluting bead TACE, transarterial radiumbalation, and also the role of pre-surgical portal vein embolization is also there. So directly coming to the therapies, ablative therapies, we all have heard about the radiofrequency ablation, and it is quite a promising technique to control the disease, especially when the tumor are small. I'll not go into the physics. Basically, it causes the cognitive necrosis, and primarily our aim is to do a A0 ablation. Means the surgeons want to do a R0 resection. The same way we also want to do a A0 ablation, where we try to cover the surrounding 1 centimeter margin of normal tissue so that we get a better control of the disease and possibly less future recurrence. So you all have seen these images, mostly done under image guidance. Ultrasound or CT, electrode is inserted, and we do the ablation. So what are the best candidates? Of course, the tumor with less than 3 centimeters. They are the best patients for any ablation. And if it is more than 3, especially with the tumors between 3 and 5, then the combination of ablation and the transarterial therapies can also be used. I will discuss it later when I cover up the transarterial therapies also. Coming to the number of tumors, there is no guidelines, frankly, to say, but it is according to the patient requirement number of tumors. We can't say that if the patient have 20 tumors, we should try to ablate small tumors, but still, there is no fixed guidelines. So 3 to 5 tumors are practically in clinical practice can be ablated in one go. And we all know that the radiofrequency ablation has a very good tumor control with very good long-term survival for small tumors. In the literature, there is plenty of literature, and when the RCTs are available to suggest that they have a curative potential nearly equivalent to the surgery and a good overall survival. And this is a case of the HCC. You can see the arterial phase enhancement washout, and you can see there are various limitations which you use to think that if the lesion is subcapsular, lesion is subdiaphragmatic, abutting the bowel. So there are various techniques that has been developed by the IR, like hydrodissection and the vascular occlusion. So nearly in the present era, there is no definite contraindication just on the basis of location basis that ablation cannot be done. That ablation cannot be done. It has become a very rare phenomenon. Coming to other ablative therapies, especially the microwave ablation. So microwave ablation, it's basically the concept is heat ablation, but the way it kills is slightly different. And the best part of microwave ablation, it basically helps in overcoming the heat sink phenomena. Because of the flowing blood, the heat sinks along if the tumor is close to the vascular structure. This phenomena is more or less in a big way it is taken care of by microwave ablation. So if we say difference between RFA and microwave ablation, it has the overall procedure time becomes less and heat sink phenomena is less, so the chances of recurrence is less and the tumor control is also good. So practically, if the lesion is less than 2 centimeter or up to 2 centimeter, more or less RFA and microwave ablation gives equal results. But if the size increases from 2 to 4 centimeter, definitely microwave ablation in all practical scenario. And yes, it is supported coming up with data also that RFA is microwave ablation is becoming superior to RFA. And in our clinical practice also, I have nearly completely switched over to the microwave ablation. So the few other techniques, irreversible electroporation. So basically, this is the technique where the lesion is very close to the vital structures like bile duct, where the heat can injure these bile ducts and cause strictures or leak. So this irreversible electroporation basically is a special method in which you kill only the tumor cells, and the normal physiological cells are preserved. So this is quite helpful. Of course, this is a relatively costly affair, and only at present only one center in Chandigarh has this IRE. And few other techniques like high frequency focused ultrasound, HIFU, as well as the cryo is also has some role at various centers, but still the heat ablation with the RFA and the microwave ablation is in the center of ablation techniques all over the world. Coming to the transarterial therapies, so basically the transarterial chemoembolization, we all know we have to inject the chemo-loaded emulsion or the particles in which the chemotherapy is absorbed, is injected to the artery of the tumor. We all have discussed that the tumor gets primarily blood supply from the hepatic artery. That gives support that if we treat the lesions with transarterial route, we get a good tumor control. So basically, it's a combined role of ischemia and the effect of the high chemotherapeutic concentration that kills the tumor, and we get the good tumor control. So basically, there are two TAs just which is conventional TAs. The doxorubicin is mixed with the lipidol and injected to the artery, and this is the first line therapy for intermediate stage stage tumors. So we should have a patent portal vein. We try to get the hepatic artery anatomy. Basically, we try to do it on the triphasic CT only. What are the tumor feeders and what are the accessory feeders which are supplying it. We try that these gastric arteries, also supraduodenal arteries, the chemotherapy agent should not go into it. And also we look for the extrahepatic collaterals. So we mix it and inject it in the form of 4:1. And now the novel, the new is drug-eluting beads where the doxorubicin is adsorbed over the surface and it causes a slow release. So if we see the old data, the two randomized control trial by Low and Lovett, we all have heard this. And if you see, I just highlight that these are the landmark articles on which the TACE becomes the standard therapy for intermediate tumors. So their selection criteria, the vascular invasion was even the branch Pvt they have not taken, and bilirubin was more than 5% in Lovett study. And see, the regularly scheduled interval TACE like chemotherapy, like 1 month, 3 months, so the TACE are repeated on record, which is not in present era. And also, whole liver embolization was performed at each session. Even for low trial, so it is also fixed. The chemoembolization is repeated 2 or 3 months until disease progresses. And on that basis also we get a significant survival benefit over the supportive care and the bland embolization. So after that, after those trials they have said, so they now what are the changes that has occurred, that the patient selection criteria has become softened. And TACE is also not only done for intermediate stage disease, but all the cases of, I will give you the examples how, like if a very small tumor and some IR is hesitant in high subarachnoid lesion and there is no other option available as a curative intent, yes, we do TACE because we have to control the disease. And also in segmental and even lobar TACE, yes, people have started doing the TACE also if the TARE option is not available. So the treatment is now on the segmental or lobar basis. There are microcatheters available. So we are treating more the patients who have slightly high bilirubin, even up to 3 if rest of the parameters are also okay. With partial portal vein thrombosis, the previously combination therapies of triple drugs are used. Now only doxorubicin is the sole therapy in most of the centers. And repeat TACE is done only if the progression is seen. So basically, after this long history of TACE, it has set up. We know the hepatic angiographic anatomy far better to go into the deeper into the artery and do the better TACE. And this has set the generation for new therapies like drug-eluting bloods, drug-coated bloods we have discussed, and also the biodegradable and radioactive microspheres also. So this is a big HCC with classical pattern, and we do the angiography, we go into the selective feeders and inject the combination, and we do it till stasis is achieved and the rest of the hepatic arteries are preserved. So there is no, we try to minimize the injury to the normal parenchyma, and this sort of response with significant tumor control we see. Coming to the transarterial radiumbalation, so at present the yttrium-90 is the most commonly agent used for transarterial radiumbalation. This is a beta emitter, so very less penetration outside the body. The radiation within occurs within the liver, and it has a 64-hour life, so we can handle it easily. The concept is it's basically inside out radiation, and because of the hypervascular tumor, these particles get circulated more in the tumor as compared to the rest of the parenchyma, and that's how we give the large amount of radiation. So our aim is try to give the radiation in about 120 to 150 gray. We try to do it. So basically, we don't, these are very small particles, so they don't block the arteries. So that's why we can do it in patients who are high risk for TACE, especially elderly people who have borderline bilirubin level 2 to 3, or even though have portal vein thrombosis, because we are keeping the hepatic artery patent, because for radiation we want the oxygen to reach there. So there are a lot of technological improvement has occurred even with the dosimetry of the tears. I'll show you with the example, like this is the big HCC, about 7 centimeter. You can see the fat standing around it because it has ruptured also. So it was not a transplant candidate. Also another lesion in segment 2 HCC is also seen. So we can see there are big tumor in the right lobe in segment 4 area and also in the segment 2 area. We go very selectively and try to find out the tumor feeders. So these are the tumor feeders, and this is the segment 2 feeder, which is exactly supplying directly everything is going to the segment 2 lesion, and this is the main feeder of the large HCC in the segment 4. So we deliver the radiotherapy directly into these vessels rather than just giving it into the left lobe. And cone beam CT, this is a major advancement where we put the catheter inside the feeder artery and we inject it and do a CT to see that we have covered the whole area. We have not left any tumor feeder, and also at what level we have to inject the therapies. And with this, we are able to give the very high radiation into the sea. This is the post-tear spect, and you can see a complete radiation, nearly the whole of the radiation has gone into the tumor feeders, and that's how the dosimetry has significantly improved, and we are able to minimize the liver toxicities to the liver. So now it is not the standard dosimetry; it is the dosimetry that we do it according to the patient's requirement and the patient angiographic anatomy, and how much is the tumor to normal liver ratio, means how many times beads are getting the particles, radioactive particles are getting more accumulated in the liver, so that the liver injury is far less in these. So if we compare with the TACE, it is well tolerated patients. The post-Imlin syndrome is minimal. If practically we see a tumor which is more than 5 centimeter, we do the TACE. Next 15 days, patients will have a bad time because of post-Imlin syndrome. The toxicities are far less as compared to the TACE. So it can be, we do it on the daycare basis, and we can say still there is no data that the survival is better as compared to the TACE. But definitely the toxicities are less. We can treat the whole liver in one go, and it can be used in the presence of the portal vein thrombosis. So we can say the surgery or liver transplant definitely is the first line treatment, and of course the ablation technique is the safe modality for small tumors which results are equivalent to surgery. TACE can be done in unresectable HCC, those who don't have the main portal vein thrombosis, and tear patients can be used who are not suitable for TACE, who are high risk for TACE. And also, definitely we have to, as Dr. Swain has, we are definitely using the transarterial therapies for downstaging for the possible future resection as well as the transplant. Thank you, everyone. I hope I was quite in time. Thank you.
Thank you, Dr. Arun. That was a very, very comprehensive and very nice presentation. You will please pardon us for not doing any questions. We are already a little late.
Yeah.
So we will just...
I have saved 4 minutes. I completed 16 minutes.
Thank you very much. Given us some time. So just move on quickly. We'll continue to talk about loco-regional therapies in HCC. And now we'll talk about radiation therapy options. And it's my pleasure to invite Dr. Kaustubh Talpatra. Dr. Kaustubh is a good friend, and he is the Chief of Radiation Oncology at the very prestigious Kokilaben Dhirubhai Ambani Hospital and Reliance Cancer Center in Mumbai. Dr. Kaustubh, are you there? Can we hand over the proceedings to you? Dr. Kaustubh?
Yes, sir.
Okay,
good evening, everybody. At the outset, I would like to thank Dr. Sachin Gupta, Dr. Doval, and Dr. Hemant Malhotra for this wonderful opportunity and introduction. So, slides are not. Yeah. So my talk would be divided into background, inclusion and exclusion for SBRT, evidence, simulation and planning, doses, constraint and toxicity, and take-home message. So let's come to the background, and I think a lot has been talked about the background. I really do not need to talk anything more. We have heard two very eminent speakers, Dr. Swain and my previous speaker. They have been talking about local therapy, surgery, and regional therapy. But still, there are patients due to medical contraindication, excessive burden of hepatic HCC, insufficient liver functional reserve. They are unable to undergo surgery. Similarly, not all patients are, of course, we understand that the paradigm of RFA has enhanced, and they do RFAs in many more patients than what was being done probably a decade ago. But still, RFA, there is a subset of patients where local treatments like RFA cannot be performed. Similarly, regional treatments like TACE, beads, radioembolization, all that we heard about may not be performed in one subset of patient where portal, we know that they can access the artery, but still sometimes it is not possible due to thrombus in the portal vein and AV fistula. These are all settings which have enhanced which has come up with a Pandora's box for treatment with radiation in hepatocellular carcinoma. The concepts have come from RFA and TEER. Why RFA? Because RFA is a local therapy, and initially we had concerns about toxicities with radiation to the whole liver. But when we learned to deliver focal doses where collateral damages were less, then the world thought that why not a non-invasive modality which can deposit focal doses of radiation. Similarly, the concept of TEER, very high dose of radiation within the tumor, and the concept came in that why not do it externally rather than inserting a catheter inside. So, as I said, initially, we were all scared about whole liver doses of 28 gray and beyond because the incidence of RILD was great, but we have learned to deliver focal doses to the liver. And how have we learned to deliver focused doses to the liver? It is by stereotactic body radiotherapy. Since it's a very varied crowd, I will not get into the details of the nitty-gritties of stereotactic body radiotherapy, but just to give an introduction, it is a very externally delivery of very high dose per fraction, very sharp dose fall off, lesser collateral damage, spares normal liver, and it is radiobiologically superior to the standard formats of radiation. What are the inclusion and exclusion? What are the inclusion and exclusion criteria for the HCC for SBRT for HCC? So initially, as it all started with Bclc A and B. So basically it is Child-Pugh A5 and A6 and some B7. And SBRT is also associated. Recently, there have been a lot of, I'll be talking about it later, in situations like bridge to transplant, in vascular invasion, in portal brain tumor thrombus, even certain BCLCCs are being enrolled. So NCCN has brought in SBRT and external beam radiation as a treatment option in its guidelines. And as we can see, NCCN has clearly written that SBRT is an advanced technique of hypofractionated EBRT, and it should be considered in Child-Pugh A, limited data for Child-Pugh B or poorer liver function. And for Child-Pugh C, it has still not been established, but for tumor thrombus, definitely yes. So this is the classification. We all know about this classification. This is not what I want to show. This is the Barcelona Clinic liver cancer staging, which our previous speakers have talked about. But this is exactly where the role of SBRT is coming in. It is in early stage. It is in the intermediate stage. And in terms of portal brain tumor thrombus, it is also in BCLC stage 3. Inclusion criteria, as I've talked about, good ECOG, Child-Pugh A5, A6, select B7, stage A to C only for portal thrombus, maximum single tumor size less than 10 centimeter, including any associated thrombus, no more than, the classic inclusion criteria is no more than 3 intrahepatic foci, adequate normal liver function reserve, CC, the liver minus GTV should be 700 cc or higher, no extrahepatic or abdominal nodal metastasis. I'll be talking about oligometastatic disease later. No history of previous abdominal radiotherapy or concomitant chemotherapy, and the bowel should be little distant. Exclusion criteria, patient more than child B7, except for portal tumor brain thrombus, which falls under stage 3, intractable ascites, active viral hepatitis, platelet counts low, liver decompensation, and if your luminal GI structures are less than 5 millimeters. So this is a very nice table for suitability of radiosurgery for HCC. This is the suitable criteria, this is the cautionary criteria, and this is the unsuitable criteria. The common references I have just listed out, and we have, our previous speakers have talked about all these kind of situations: failed RFA or failed trace procedures, portal venous thrombus, unsuitable for transplant or surgery, vascular malformations, and there are few more. Evidence, I will just run through the evidence because there is many. This was earliest when it began. Blomgren in 1998, total of 20 tumors in 11 patients. Treatment was delivered 1 to 3 sessions with 5 to 15 Gay per fraction, and the overall response rate was 70%. With that, in 2013, the landmark study of a sequential phase 1 and phase 2 trial, they enrolled 50 patients in the phase 1 and 52 patients in phase 2. And if you see in phase 2, the local recurrences was much limited, and even death without local recurrences, the graph was good. The median overall survival was 17 months. And hence, many series, many single arm studies, many retrospective series. And what has happened is, if you see, generally people have been delivering for dose of to the tune of 35 Gray to 50 Gray. 1 year overall survival is to the tune of anywhere between 55% to 90%. And in the recent series, the grade 3 toxicities have come down, which I'll be talking about. This is a study of RFA versus, it's a very a study in 224 patients. SBRT had patients has received at least 2 previous treatment, but the local control in the multivariate analysis, they saw the local control due to SBRT was independent of that of RFA. So if we go through this table here, you see the grade 3 toxicities now in the later series, they are really coming down, and usually median they are to the tune of around 12 to 13%. The 5-year local controls have enhanced, they're anywhere to the tune of 3-year local controls are to the tune of 75 to 90%, and SBRT is being incorporated in various treatment paradigms of late. So as I said, the recent local grade 3 toxicities are much better than what it was. So apart from standard HCC SBRT, which we have been talking about, Dr. Soin has very nicely elucidated the role of SBRT as downstaging for bridge to transplant. And I think they have extremely good experience about it. We have also started doing it, and our numbers definitely are not as big as theirs, but it is a very encouraging modality, and many more patients are transplantable as compared to what it was before. Similarly, after Palma's study came, David Palma's study came 2 years ago, SBRT for extrahepatic lesions is the overall survival is 41 months, but that is for all comers. That was not only for HCC, versus 27 months with the addition of SBRT to standard care of systemic therapy. So with all this evidence, I think we are establishing the role of SBRT. What is merited is good phase 3 randomized trial. IAEA has embarked upon a phase 3 randomized trial, that is SBRT versus stays, but I do not think they have enrolled much. This is another landmark trial. We are awaiting the results. RTOG 1112, daily sorafenib versus SBRT followed by sorafenib. This is the stratification criteria, and I think we are going to have some enlightening results from the thing. For the radiation oncology audience, I will just be running through what is simulation and planning. So patient preparation, medical gastroenterology evaluation, patient with varices should be considered for prophylactic banding, patient with raised HBV antigen or viral titer should be on antiviral therapy for at least 2 weeks, and SBRT should be planned 4 to 6 weeks after last TACE. High quality triphasic scan, that is important. How do we contour? What are the CT scan protocol for SBRT? Triphasic scan in some form of respiratory motion management system, which we'll be talking about. A 4D CT, good contrast, arterial phase, portal phase, and venous phase have to be documented. So review imaging with the diagnostic radiologist, triphasic CCT and dynamic MRI fusion. For contouring, you do not need to do PET CT, but as Dr. Soin said, to see extrahepatic disease, you may do PET CT. Background of cirrhosis is very important. So identify cirrhosis. In the background of cirrhosis, please identify the regenerative nodules from the tumor and don't start continuing the nodules. Please identify the areas of previous treatment and vascular thrombosis. The respiratory motion management strategies, I think it's beyond the scope of this talk, but it can be many. Medanta, Dr. Soin said they have been using ABC. We are doing RPM-based gating, Calypso-based gating, and abdominal compression. So I'll just be showing the images. This is a picture of RPM, respiratory positioning management-based gating. That is, you acquire the CT scan of the patient in 4 dimensions. You bin them in enhancing, that is 90-10, 80-20, 70-30 inspiration-expiration phase. And then you create the tumor volumes based on that. So each phase has a bin, and those images are contoured in that. And then finally, you generate the internal target volume. So you get the overall picture of the whole moving target. This is how an abdominal compression plate looks like for the radiation oncologist. We have got a compressor-based compression plate and a pneumatic compression plate. The picture of that is not here. This is how a 4D CT target looks like. You are being drawing in various phases. This is a large HCC, and if you contour in various phases, you will have to eventually generate an internal target volume, which will be larger than your static images. This is how you gate. You ask the patient to breath hold. Gating is a breath hold technique in RPM systems, and you ask the patient to breath hold in one particular phase of respiration, and that is when your radiation beam is on. Otherwise, your radiation beam is off. For all these things, you require training and compliance in breathing techniques, deep inspiratory breath hold, the respiratory positioning management system. Training the patient is very important. Start coaching the patient 3 days prior to starting the SBRT. I had been talking about the scan. So all these 3 phases have to be acquired for contouring for SBRT, the arterial phase, the portal phase, and the venous phase. Thrombus definitely will be seen better in the venous phase. For tumor contouring, usually we use the late arterial phase. These are the structures which need to be contoured. I do not need to get into the details of it, but it is a tedious process, and all these structures have to be identified and contoured for SBRT liver. Gross tumor volume, contour all parenchyma and vascular changes related to the HCC as seen on the CT scan. Any gray areas have also to be identified. Clinical target volume is same as the gross tumor volume, and planning target volume based on the institutional protocol. On ITV, I still prefer giving almost 4 to 5 millimeter. If you are not drawing the internal target volume, it should be at least 7 to 8 millimeter. Dose, does it have a dose response? There is various studies. I mean, some studies have said that for smaller region, the dose is lesser. For larger lesion, the dose required is more, and then it plateaus out. Similarly, is size important? In local control, yes, size has turned out to be important, but in terms of recurrence-free survival, size in this particular study did not show to be important. How much liver will you spare? If you ask a student, they will say 700 cc of normal liver should receive less than 15 gray. Yes, that is a very ballpark statement that we talk about. But this is the strategy we follow. If you're planning for 50 gray, you have to keep your mean liver dose to 13 gray. If you're not achieving that, reduce, try to achieve 15 gray, not achieve, reduce the total dose to 40 gray, and henceforth and beyond, below 30 gray. And if you cannot achieve your liver doses, please do not enroll those patients for SBRT. The standard constraints for OAR, this is what the dose all these structures should receive. Toxicities, the last few slides. Apart from other toxicities, two things I should talk about. RILD, that is radiation-induced liver disease. Currently, the incidence is less than 5%, which is classical, and the non-classical RILD, which includes elevation or liver enzyme and decline in the liver function within 12 weeks from the start of therapy, which is less severe, less dangerous, but the incidence of it is around 20%, but most of the current series are showing grade 3 toxicities or beyond in the tune of, as I said, 10 to 12%. This slide I have shown before. This slide sums it all. Most of the series had patients with tumor vascular thrombus. Few of them had extrahepatic disease. These are the dose vaccination anywhere between 35 to 50 gray. These are the acute liver toxicities and local control I have talked about. So my last two slides. Take home message, we need to do more randomized controlled trial. IAA has embarked upon one very good trial, but not much is happening there, not many enrollments. Emerging evidence, but very useful, non-invasive, enhanced usage in the last 5 years. I've talked about where you should enroll. In cases of portal venous thrombosis, it's a very effective option. In bridge to transplant, I think in coming years, we will see more and more centers adapting it. Emerging role in oligometastatic extrahepatic disease. What we need to combine is with various therapies to optimize our outcomes, optimize the local controls and survivals. And in future directions, we need to utilize integration therapy like RTOG 1112 has integrated Sorophenic with SBRT. I believe SBRT is here to stay, and it is a very good non-invasive option where, because of the way you can play with beams, the limitations of delivering your radiation doses are few. So SBRT is definitely a current option and going to be even a better futuristic option. Thank you.
Thank you very much, Dr. Costa, for an extremely good overview of radiation therapy in HCCs. Again, in the interest of time, we will quickly move on. Please pardon us for not permitting too many questions. You did finish on time. Thank you for that. I'd like to now request my dear friend, Dr. Harit Chaturvedi. Dr. Harit is chairman. Sachin, you have a comment?
Sir, yeah, I think we can go ahead. We had excellent lectures. We have covered the loco-regional treatments very well. Dr. Piyush set the stage with his diagnostic things lecture, and Dr. Soin, Dr. Arun, and now Dr. Costa had really enlightened us with their excellent lectures. I think as medical oncologists, we actually required to listen to all these 4 lectures. So that has freshened up our knowledge. And let's listen to Dr. Chaturvedi, what he has to say now.
Very true. Completely agree with you. So now we'd like to request Dr. Harit Chaturvedi. Dr. Harit is a very dear friend of several years standing, several decades standing, in fact, and he's chairman of oncology at very important and prestigious Max hospitals. And Harit will summarize the session and give us his views on the multidisciplinary management, which is essential in today's times for our patients of HCC. Dr. Harit.
Thank you, Hemant. Thank you for that introduction. And I want to congratulate Sachin and the whole team there for really organizing such a wonderful event, because I know we are having so many online interactions, seminars, meetings, but there's quite a fresh air I can feel right here in this room, because the plan is very good, the talks were wonderful. And I just want to, as an expert comment, I would say that the real experts had just spoken, and they've actually spoken very well on local regional therapies. However, I want to make 2 comments. One is that quite often it looks as if we are all competing for the same space, where surgery and local IR interventions and SBRT and radiation. So in true sense, the multimodal integration truly evolves when we sit down and discuss each patient and brainstorm and plan in our tumor boards. So the culture of tumor board is real delivery of these infrastructure and people and knowledge bank, which delivers to the patient on ground. And also, as I heard the speakers talk, as Arun said, that I have almost completed shifted from microwave from RFA for lesions more than 3 centimeters, or for that matter, Dr. Kaustubh mentioned that we have tied over that era when we were hesitant of giving whole liver radiation and understood what are the possibilities. So there's a continuous evolution happening in the space of treatment for HCCs, like in every other area. And that again invites us to engage more and more, to talk more about and try to understand more about other specialties. And only as you learn more from other specialties, you use your one more judiciously in a better way. So I'm also aware that in the panel discussion, we have got cases and we are going to further dissect this, but the surgical options quite well discussed by Dr. Soin, as expected, that not just transplant, the resections, and I would say that one must emphasize on the usage of resections properly, because in our country, where the donors are limited, the cost of transplant is huge. We should use every possible modality to maximize the benefit for the patient. Likewise, IR access is limited to few hospitals in big cities. At the same time, as it is evolving, it is really not emerging. It's already emerged as the 4th therapeutic modality in cancer treatment and is playing a significant role. So all of us who are enjoying the benefits of IR know that how much more important it is to reach all far and wide. And radiation, what more to say, that it is a continuous. Proton is, now we have 2 centers, in next 10 years, we'll have 20 in India. So say all this will continuously evolve as SBRT and fine tuning and better radiation will evolve, these things will happen. So that's all I wanted to say, that it's a continuous learning, and thank you very much for having me here. Thank you.
Thank you, Dr. Harit. On behalf of my co-chair, Dr. Dinesh Doval, and myself, we thank the organizers for this opportunity. Dr. Doval, any closing comments from your side before we hand over to Sachin? Please unmute.
We are short of time. Let's give the mic to Sachin so that he can proceed to the second session.
Over to you, Sachin. Thank you.
Thank you so much, sir. So thank you, Dr. Doval, sir, Dr. Hemant Malhotra, sir, and Dr. Chaturvedi, and my previous speakers, Dr. Piyush, Dr. Kaustubh, Dr. Arun, and Dr. Soin. So we had excellent things, and we had a lot more to come. And I will invite my next chairperson, Dr. Brigadier Rajeshwar Singh, for taking over from here for the next session. And he's a well-known personality, and he's actually our mentor in this region, in Tri-City and North. So we look upon him for advice and guidance. So, sir, please take over, and I'll request Dr. Sham Agarwal to please save a few minutes from the panel discussion so that we run on time. Thank you.
Thank you, Dr. Sachins. Thanks for the kind words. And we had a lovely discussion on local-regional therapies in HCCs. And as Dr. Chaturvedi said, it's a small space where all the three specialties are involved in this. And now we're coming to the tumor board and see how each specialty has got what space in this. And to carry on this, none other than it's a great pleasure to introduce Dr. Sham Agarwal. He's been a doyen of medical oncology and oncology in especially northern India for 1 decade now. He's heading the oncology department in Gangaram Hospital. So not wasting time, I go on to the panel discussion and request Dr. Sham Agarwal to please proceed with this and kindly introduce your speakers also, panelists also. Thank you.
So thank you very much for the kind introduction, and always love your comments. So thank you very much. So I think we are hard pressed for time. Sachin has already said that, and maybe we'll try and discuss only one case here. So I think we have a galaxy of panelists. Dr. Anubha is the medical oncologist from Jalandhar. She's there. Dr. Rajiv Saini from Jammu, medical oncology. I see Dr. Sajal Kakkar and I think Dr. Pankaj Kumar, who are the radiation oncologists from Mohali. We have Dr. Vivek Saxena and Dr. Tegbir Singh, from Delhi and Mohali, respectively, as interventional radiologists. Dr. Shraddha, Dr. Asit are the surgical oncologists from Mumbai and Delhi. I'm not sure whether Nikhil has joined from Delhi. He's a surgical oncologist. So I think
Nikhil is not there, and Dr. Pankaj could not join. His son was not well.
So right.
So Dr.
So
Sajal is there.
So I think we have heard from the experts what should be the approach for, where should we use the intervention radiology like taste tear, where we should operate, where we should go for transplant, RFA, etc. So let's go with the first case and see. And so there can be a fight between various oncologists and intervention radiologists and radiotherapists for cases. So this is a young patient, 35 years old, HBsAg positive in 2013, with some background history of jaundice. Otherwise, okay. Next, please. So this is mild ascites, and the ALT, AST are 3 times elevated. Bilirubin and albumin are normal. Platelets are 90,000. And HBV DNA is, pretty high, as you can see here. Next. So there is cirrhosis of the liver with ascites, and there are varices grade 1. So this is HBV-related liver cirrhosis, child A, and the patient is on supportive care and diuretics. Next, please. And of course, the patient is on the antiviral drugs. So the patient is on regular follow-up. There's worsening of ascites and esophageal varices. Imaging shows cirrhosis, portal hypertension, but no mass. That is after 1 year. And the patient is continuing on antivirals and the diuretics. Next, please. So this is, 2 years down the line, patient starts developing weight loss, cirrhosis of the liver. And now for the first time, you see a 7 into 5 centimeter mass. And there are 2 more lesions with portal vein thrombus, and the alpha fetoprotein is 10,500. So this is, I think, a fairly common presentation in a person who is being followed up by gastroenterologists or liver specialists, that they start getting weight loss and a mass and the portal vein thrombus. So I think this patient, of course, undergoes a triple phase scan to confirm that this is nothing else but a hepatocellular cancer. So I think my question first to the surgeons. Let's come to the surgeons. Dr. Shraddha Patkar. So can I have the next slide? Yeah. So these are the pre-treatment assessments. So Dr. Shraddha, what is the role of surgery in a situation like this? Is it ever going to be there, or it is out forever? That is my question.
So considering his age, I wouldn't write him off forever, but at the same time, I wouldn't consider him for an upfront surgical resection simply because he's given a history of decompensation and over a period of time develop worsening of the liver failure. So it will be probably prudent to offer him some sort of liver-directed therapy, see how he withstands the procedure, and that can be taken as a stress test that if suppose we have to intervene with a surgical resection later on, he would be able to withstand it. Not upfront candidate, but not completely writing off either.
So you're not writing him off. Great. So Dr. Asit, do you agree, or you think this patient is doomed and is going to be having a few years with the interventional radiology, etc., which is what we are going to discuss? Dr. Asit, please.
Right. I think surgical aspect, if you ask me, so there are two surgical options that we can discuss here. One is transplant, which is a part of surgical option, and second is a resectional procedure. As far as I'm concerned, and what most of the literature supports, is that any patient who has developed ascites is usually not a candidate for any resectional procedure. As far as transplant is considered, a patient who has a decompensated cirrhosis and who has HCC, now, we know that Dr. Soin has elaborated it nicely, that number of tumor, the size of tumor is not a contraindication. If his general condition is good, is fit enough, and there is no widespread metastasis and no portal vein tumor thrombosis, main portal vein tumor thrombosis, yes, this patient is definitely a candidate still for transplant-oriented surgery. But as far as resection is considered, this particular patient is not a candidate, not now, not right.
So at the moment, the portal vein thrombus will not permit him for direct, a transplant kind of a surgery, right?
So one thing that we have to establish is this a bland bland portal vein thrombus or a tumor thrombus? If it is a tumor thrombus, yes, this patient is not a candidate for transplant. But if it is a bland thrombus, yeah, in this particular patient, one important contraindication, if I talk about this particular patient, is its AFP of more than 10,000.
Yes.
That is a contraindication for transplant in this particular patient. So if you ask me strictly for this patient, he's not a candidate for liver resection, he's not a candidate for transplant for me.
Great. So I think you made excellent points here, that the portal vein thrombus, which was seen on the CT scan, I think we need to evaluate whether it is a bland thrombus or it is a tumor thrombus, because that has a bearing on the management of this particular individual. So excellent. So before I go to the real people who are going to be involved in this patient, let me talk to the medical oncologists, Dr. Anubha and Dr. Rajiv. So Anubha, this patient comes to you. The patient, has the hepatitis controlled now, and portal vein thrombus is there with a lesion, as I've shown you. So, any role of your immunotherapy and, lenvatinib or whatever you have. Anubha. Is Dr. Anubha there? If not, then Dr. Rajiv, I can see Rajiv, if he can make a comment here.
Sir, I'm here, Anubha, and
yeah,
I guess...
You go first, yeah.
Yeah, so I think right now there is neoadjuvant systemic therapy is a field that is evolving, and there is some data that has shown that, the combination immunotherapy, etc., for a patient who is not an upfront candidate has, they can have like a 20 to 30% CR. There is some data coming up, but that is not the standard right now. So right now, I would say maybe a few years down the line, we'd be better prepared. We know that with the Pembro, lenvatinib, or the bevacizumab, Atezo, they have a good response rate, and right now they're in the advanced setting with the potential to move into the neoadjuvant setting, but not as of today.
Not as of today. Dr. Rajiv, if this patient comes to you, what more would you like to do before, you hand it over to maybe somebody else?
Sir, in such patient, basically, as we know, there is no other extrahepatic disease in such patient. It will do a PET scan to rule out other extrahepatic causes.
Perfect.
So if the disease is localized only to liver and patient has portal vein thrombosis, we'll give option of tear to such patients. But if patient is not willing or he cannot afford, then we'll definitely provide some systemic therapy depending upon their economic status.
Right. So I think the issue which Dr. Rajiv Saxena raised was to wanting to pick up extra hepatic disease by way of maybe doing a PET CT scan. to before the patient is handed over to the maybe radiation oncologist or to the interventional radiologist. So that could be a thought process. But as Anuba said, there's no clear role of neoadjuvant therapy at this point in time. So Dr. Tegbir Singh, who's the intervention radiology from Mohali. So what do you think you will be doing with this patient, sir?
Hi, good evening, sir. This patient, considering the background of portal vein thrombus, tumor thrombus, of course, we have to rule out a bland thrombus or an enhancing tumor thrombus, is definitely a patient for tear. So a tear cert Y90 here would be an ideal thing as the best palliative management. In case we are able to achieve a step down bridge to transplant success, that is the portal vein thrombosis gets cleared off and is off of a vascular invasion from the tumor thrombus, he might as well go in for a liver transplant and be with a curative intent thereon. But as of now, definitely yes, a palliative intent with tear. That would be my take on this patient.
Right. So
plus,
a great
I would really want to add over here is I would.
Yeah, go ahead.
I would really want to add my tear and would definitely have something like a Sorophenic or a levodopa going on, and also would want to consider the acetazolamab and the immunotherapy options which are being derived now and which are being well thought of in the international literature right now. But Sorophenic is working well for the patient subset in my center. We've been doing well with patients on Sorophenic post tear. They do well and the longevity increases, and probably we have good results with that as well.
So it seems Dr. Tegbir agrees with the tactic study where they have combined tear with drugs like the TKIs with some benefit there.
Perfect, sir. Yes, I do.
Yeah, we discussed a lot about tear, but the most important point of cost factor has not been considered. So people cannot afford tear most of the time. Dr. Vivek, what would you do if the patient cannot afford tear? Tear perhaps is the ideal maybe in this situation, but patient doesn't have the money. What do you do then?
So there are 2-3 things that we can do. One is that we can combine SBRT with if the portal vein opens, depending on how extensive the portal vein thrombus is.
So you do SBRT to what?
To the portal vein thrombus. And then if it opens, then we can offer TACE to the patient.
Okay. So first we go ahead and do the SBRT to the portal vein for a week or so, and then you wait for 4 weeks, right?
Absolutely.
And then you can offer TACE.
Then we do a triple phase CT and see whether the portal vein is open.
Okay.
And then we can offer TACE to the patient.
So is that what you will offer this patient if the patient can't afford tear?
Yes.
Okay, so we've come to SBRT to the portal vein. Dr. Sajal Kakkad, please, what do you think?
Good evening, sir.
Yes, sir.
Yes, the patients with PVT nowadays, we just can't write them off. And as rightly being discussed here, we should offer them some sort of treatment. And radiotherapy, especially the SBRT, has shown quite good results with patients with portal vein thrombus. But in this situation, and particularly in this patient having ascites, so we need to consider that before giving SBRT to this patient. Patient having moderate to severe ascites or refractory ascites, probably I would be skeptical to offer this patient SBRT. So, but otherwise, if it's a mild ascites, yes, SBRT can be definitely offered in this patient with portal vein thrombus. And it has shown very good results.
Yeah, so what about the liver lesion? Would you give SBRT to both portal vein and to the liver lesion, or just do one by one?
If I am offering SBRT to this patient, I would like to treat both the thrombus as well as the tumor, liver lesion also.
Size here was pretty big actually.
Yeah, the size is pretty big.
Yeah, I know. So Dr. Sajal, what is your, the maximum size which you would like to irradiate in a child book A?
Usually in SBRT, patients with liver lesions up to 3 lesions would be preferable, and maximum size I would prefer if less than 5 centimeters, not more than that. And obviously, yes, the liver reserve is very important. The functional liver reserve.
Child book A, which means there's a fairly good reserve there.
Yes.
So less than 5 centimeters each, which is like up to 15 centimeters.
Up to 15 centimeters, correct? Yes, sir.
Right. So Sachin, I think you heard the expert saying that they can go up to even 10-12 centimeters, if the liver function is fairly okay. So Dr. Vivek, You said, you want to give SBRT first to the portal vein, and then if it opens up, you would like to do interventional TACE.
No, sir. I said if tear is not feasible to the patient, then only.
Yes, of course. So, as I said,
tear
TACE
is the
not
first
affordable
option.
by most of the patients. Let's accept that fact.
Yeah.
15 lakhs is not there, in the pockets of people, more than 5%.
Yeah, so I'm sure Dr. Sajal can correct me, but even with mild ascites, they can give to the portal vein. Maybe giving to the entire tumor would be a little difficult because it's 7 centimeters. And the child's spew scoring that we did, I think was 2 years old that was being shown. So I don't know what the current child's spew score is.
Child spew way even now.
It's even now. Okay.
Yeah.
Yeah, with mild ascites, sir, it's not a problem with us.
Mild ascites is not generally not a problem.
So what I'm getting in this patient, which is not an uncommon situation, a fairly biggish tumor, 5, 6, 7 centimeter tumor with portal vein thrombus. I'm getting two views here. One is to go for, radiation to the portal, SBRT to the portal vein, wait for 4 weeks. If it opens up, do TACE, or the radiation oncologist can take over the entire situation and do the SBRT to the portal vein as well as to the tumor, right?
Yes, sir.
Yeah. So Dr. Shraddha Patkar, are you happy?
Sir,
Dr.
the intent.
Yeah, Dr. Tegbir, please. Yeah.
Sir, the intent with tear would definitely be something from palliative to bridging to curative intent. Definitely, yes. You're very right, sir. Cost is a big factor.
Yeah.
And what I'm talking about is lakhs and lakhs and lakhs of rupees.
Yes.
Is tear and probably another session of tear or probably another TACE and then probably a transplant, which is almost near to 1 crore of rupees. Definitely. But leaving that money part out of it, in case we are going in for tear, this is probably a bridge to what I believe is a potential cure. Now here, something is what sells me the therapy of tear and probably a bridge to transplant. So I would want to consider that. Money definitely is an issue.
Hold on, Dr. Tegbir. So I don't have the money at the moment, 14, 15 lakhs to spend on tear. So
Right,
I go for SBRT to the portal vein.
Right, sir.
Which is much cheaper. With or without SBRT to the liver lesion or a TACE if it opens up. That is also a bridging for a transplant,
Exactly, yes. That should be done. Yes.
Why should I spend? I don't have 14 lakhs.
Yeah, that's there, sir. I mean, the point here was we should try for a transplant if in case it's possible, if we can bridge from a palliative to a curative intent.
So what
we should aim for that.
The point is that we can do a transplant with the SBRT to the portal vein and an interventional TACE if it opens up.
Right, sir.
Or I can do SBRT to both and then go for a transplant.
Right, sir. Right,
so
sir.
Why should we go for tear then? What is the point?
I don't, sir, but then I wouldn't want to know the results in the same thing. But then, of course, I need to be corrected here. But I believe tear is probably faster, quicker.
Okay. So Dr. Shraddha, I mean, are you happy with the tear and then transplant, or radiation followed by transplant? Or Dr.
So it's simply because we are more comfortable probably resecting after doing some sort of liver-directed therapy, and it can be done post radiation to the thrombus followed by TACE or giving the SBRT. Either or would be quite okay. It's just the comfort level of the surgeon which is there with either operating in a radiated field versus a TACE. The experience is a little more with operating post-TACE rather than radiating the entire liver. So what I would prefer is probably giving radiation for the thrombus. Then if it opens up, doing a TACE. Otherwise, if it doesn't open up, give radiation as a definitive treatment for the entire liver tumor, taking into consideration that the size is little more than what we would be happy with, and then see how he is responding.
Okay, final comments from Dr. Asit, the surgeon, please.
Right, sir. So, I mean, if we strictly stick to this particular patient with the amount of AFP levels he has, I don't think ideally many people will consider him for transplant, one. Secondly, with this AFP level, I think PET-CT is mandatory. It must be done. And if your primary lesion shows an intense FDG ability, again, that's a poor biological character, and it might throw up few metastases here and there. And also what I get from the presentation that you made, sir, that this patient had deteriorating liver reserves. He developed ascites requiring accelerating dose of diuretics, and he also had a incidence of decomposition in form of jaundice. I don't think this patient would tolerate any radiation to liver per se. So, I mean, what we are discussing in theory might sound right, but if you are discussing in respect of this particular patient, I think he will end up with best supportive care. That's my personal take.
Okay, so
I think the liver function is what is going to decide his ultimate outcome rather than the liver-directed therapy per se. We should probably maybe give him some time to see how his liver function pans out and then plan whatever treatment we are planning.
Absolutely. So I think we've had a fairly good discussion looking at, the liver function, severity reserve, portal hypertension. So one needs to individualize. Just looking at a biggish tumor, a portal vein thrombus, especially if the liver function is preserved, I think we must not be writing off these patients. So you do have the option of SBRT, which should be incorporated. We do have the option of course, TACE and TARE. So I think, as was said before, a multidisciplinary tumor board for individual patients is going to be helpful. And I think I've learned a lot today from the lectures and from this discussion. And since we are hard pressed for time, I thank all the panelists for this interactive panel discussion. And thank you, Sachin, for inviting me to moderate this panel. And over to the chairperson, please. Thank you very much.
Thank you, Dr.
Thank you, so much.
That was a wonderful case discussion, and it was eye-opener as a medical oncologist with a patient with such a large lesion and ascites. We are still thinking of, though not in this patient, but we can still think of curative option in such patient. This was not in our mindset a couple of years back, which is coming now. So it was a wonderful. I thank Dr. Sham and all the panelists for this lovely discussion. And now we proceed to the next topic, that is adjuvant treatment after local regional therapy in HCC. It will be given by Dr. Viraj from Ahmedabad. Dr. Viraj, please start with the presentation.
Thank you, Chairperson, and thank you, Dr. Sachin, for having me here. Earlier today, I asked Dr. Swain about a very blanket question. What is the standard of care for adjuvant therapy at Medanta? In about 2,000 cases that they did, and it was a straightforward answer, no. So technically speaking, Dr. Sachin, my talk is very easy. Adjuvant therapy for HCC post-local regional therapies, post-resection, post-liver transplant is technically a big no right now. However, as a medical oncologist, we are encouraged because we are blessed with so many systemic therapies now in advanced disease, as Dr. Bharat is going to talk. And we want to dip our own fingers, whether can we use them in earlier stages. So we know that recurrences after operation or after liver transplant is as high as 70%. And we heard Dr. Swain saying it's 60% in his center at 3 years, which is a very, very high unmet need. So just by doing operation for even early tumors and leaving them alone, half of them are going to die very soon. But unfortunately, all the contemporary studies are negative. They do not improve recurrence-free survival. And as rightly so, the American and European guidelines do not recommend adjuvant therapy post-resection or ablation. However, as I said, we have newer systemic therapies, and incorporating them in earlier stages appears promising, and we will just see a few of the studies here. So what's the rationale? HCC is a different disease where we have something called as two types of recurrences. The type 1 recurrence is typically the disease which is coming back because of the micro metastasis. And we have something called as type 2 recurrences, which are actually not the recurrences, but they are the new tumors developing in the underlying cirrhotic or the poor liver reserve that we have. So majority of the trials which are positive today for adjuvant are for type 2 recurrences, where we use antiviral agents for hepatitis B and C. Now, earlier, about 2-3 decades ago, this was a landmark paper in New England Journal of Medicine about using retinoic acid after operation of liver, and they clearly showed reduction in recurrence rate by half. This was a small study from Japan. Unfortunately, did not make to the guidelines because other institutes could not mimic the same results. But this was the starting where we had something after operation was beneficial rather than doing nothing. We have antiviral therapies like entecavir, lamivudine, tenofovir, and what have you not. This was presented in JCO about 10 years back, that if you give antiviral therapy just after operation versus you don't give them, there is improvement in survival because this probably reduces the type 2 recurrences, which prevents further new HCC. Similarly, from China, we had plethora of studies for edafovir for high viral load, and we have the same group showing for telvivudine for low viral load, that if you give antiviral therapy for hepatitis B patients after operation, it improves recurrence-free survival as well as overall survival. Interesting thing, what was found a couple of years ago is just a single dose of TACE after HCC resection improved recurrence-free survival and overall survival. This is new, and people are exploring this option more, TACE, TARE, SBRT after liver resection to prevent recurrences, kind of adjuvant data. Unfortunately, this has still not made to guidelines, but a majority of China and Korea are using this strategy for after liver resection. Something very interesting came through when I was preparing for this talk is Chinese medicine, the traditional Chinese medicine, large trial of 1,000 patient data or randomized phase 3 trial using mushroom extract, they call Hoyer's granule. And this was published in Gut. For people who know, Gut is a very, very well-renowned gastroenterology journal. The impact factor is more than a JCO or Lancet we have for oncology. So something they thought important. Unfortunately, this is not used in majority of centers outside China. Now, what we know that doesn't work is the chemotherapy, like capecitabine, we have gemcitabine, we have adriamycin. All of these have been tried in smaller studies, and they could not convincingly prove that there is reduction in recurrence-free survival and overall survival after liver operation. One of the largest contemporary trials that we have today was with sorafenib. People thought sorafenib would work like it works in metastatic disease after liver operation. And we had a STORM trial, a large 1,000 patient data. 500 of them were given sorafenib and 500 were not. And you could see there was no difference whatsoever in recurrence-free survival. Also, there was no subgroup which benefited more. There were about 25% of cases which were whites, Americans and Europeans. Neither they benefited nor the Asians benefited. None of the child grouping did benefit. So essentially, after this study, sorafenib was dead in an adjuvant space. I heard one of the expert in the panel talking about using sorafenib as an adjuvant to TACE. We have two big studies, TACE2 and the SPACE trial. They were published about 5 years ago, which showed no benefit of using sorafenib after TACE in intermediate stage B HCC. However, Dr. Sham Agarwal did mention about the TACTIC study, which was presented last year, where using sorafenib after TACE improved recurrence-free survival by magnitude of almost double. The difference about TACTIC study as compared to the TACE2 and the SPACE study was they did not use RECIST as the modality to call it a progression. So 1 or 2 liver nodules here and there popping up after TACE were not considered progression, and the investigator was allowed to continue sorafenib as per his or her discretion. And perhaps that was the reason that the recurrence-free survival was improved. And we could see that this year in ASCO GI, there was an update on overall survival just 3 months ago, and we have no overall survival advantage with using sorafenib after TACE. Tactics was very encouraging, but unfortunately, we are back to square one. So I don't think so sorafenib must be used after TACE or TAR. Interesting data we have for lenvatinib with the newer TKIs after TACE. Again, this was presented last year ASCO. A small study, about 100 patients. They showed that if you do only TACE, it's 8 months. If you do TACE plus lenvatinib, it is about 12 months. We need to wait for overall survival data and a bigger cohort study before we start incorporating. I wouldn't lie by saying that I have personal experience with lenvatinib after local regional therapy. We don't know simply whether it will help or not. The time will tell us. And everybody is excited about immuno-oncology. All the 4 major immuno-oncology drugs like Nivo, Pembro, durvalumab, and Atezo all have launched phase 3 in an adjuvant space with Checkmate 9DX, Keynote 937, Emerald 2, and Embrave 050. All of these will be coming in next 2 years, and we'll have plethora of studies to talk about in this space. But until then, this remains still experimental. Last slide before I wrap up, something interesting, what Dr. Anuba also mentioned, we are moving from right to left in BCLC. We are going for neoadjuvant space now. We want to go even before operation as medical oncologists. And this was a proof of concept study presented this year's ASCO GI using nivolumab for 2 months along with cabozantinib. It was a proof of concept study with just 15 patients, and you could see the, very nice responses, and about 12 out of 15 patients could undergo R0 resections, and about 5 of 12 patients had complete pathological response. This does tell us that perhaps we can move from right, which is BCLC-C, which we were always left to, and now we are moving towards BCLC-B or even perhaps BCLC-A. So to conclude, adjuvant sorafenib or any other chemotherapy is not recommended today as a routine practice post-resection or transplant in HCC. Lenvatinib, a newer TKI, plus any local regional therapy looks promising. Of course, we need more data. And we are eagerly awaiting IO data in adjuvant space. And like I said, we are moving from right to left, and neoadjuvant studies are exciting. Thank you.
Thank you, Dr. Viraj. You've been given the most difficult task of presenting where data was not there, and you have still managed to keep us, engrossed in this and very nicely presented. And I know that there was nothing there in ICC for last 2 decades, and certainly now plethora of drugs have come. And rightly said, from left to right, we are going to move from the metastatic to adjuvant to neoadjuvant. And thank you for a lovely presentation. With this, I conclude this session and hand over back to organizer. Thank you, Dr. Sachin.
Thank you, Dr. Brigadier Rajeshwar Singh. And I totally copy your comments regarding this talk. Viraj, you have done an excellent job, and it was really difficult, and we actually didn't know what to do. And we faced this situation a lot of times, and we are actually a lot of times we are excited to use these drugs without actually knowing, and we feel that it might be helping the patients, but data is not supporting at the moment. So let's see what immunotherapy does in coming years. Thank you so much for helping us with this lecture. And now we move on to our next set of lectures and panel discussion, so which is totally space of medical oncologists now, and so we're eagerly waiting for this. And I invite my chairpersons, Dr. Sunandan Sharma, he's Chief of Surgical Oncology at Max Hospital in Mohali, and my colleague, Dr. Gautam Goyal, who is a medical oncologist, senior medical oncologist at Max Mohali. And so over to you, both of you, and to invite the next speakers. Thank you.
Good evening, everyone. So our next topic is on the management in HCC with the medical oncology, all the drugs which we are looking forward. So the first of all, I will invite Dr. Sumit Goel. He will present a talk on upfront and second line TKI in hepatocellular carcinoma. What is the current status at this hour? Dr. Sumit Goel is a consultant medical oncologist at Rajiv Gandhi Cancer Institute, New Delhi. So request Dr. Sumit to go ahead for the talk.
Okay. Good evening, everyone. Two questions. Hope I'm audible and my slides are visible.
Yeah, go ahead, Sumit.
Okay, thank you. Thank you, Sachin. Just starting the PowerPoint now. Okay, so my task today, thank you very much for giving me this opportunity. So my task is to talk about the data which exists today in upfront and second line TKIs in HCC. So very briefly, I will try to cover whatever data we have. So we know all this hepatocellular cancer, it is ranked as 6th most common neoplasm and 3rd leading cause of cancer and death. Day by day, we are seeing more and more cases. In India, Globocan 2018 data, incidence of HCC is projected to be around 27,670 people we are likely to see. We all know incidence is increasing. We are getting to see more patients. It may be because we are more aware and we have more better modalities to pick the disease. So if we look at the treatment modalities which existed 10 years back, in 80s, it was only the surgical modalities. TACE was the predominant, then there was liver transplant and resection. So moving on till next for 2 decades, we had nothing. Then in 2007, the FDA approved Sorophenic in first-line HCC, which was nothing short of a breakthrough. Subsequently, and for another 15, 17 years, there was a big void. There was nothing to address, and we had only Sorophenic. Then lenvatinib came, nivolumab, regorafenib, pembro. All these agents got approved one by one. Now the way the molecular and precision oncology is taking over, every day is this new data which is coming up, and it is like Sachin said earlier, it is for us, we want to use these medicines, but there are barriers and limitations. Definitely, the field is more exciting now, and results are also there. So we know liver cancer, it is a complex process resulting from combination of epigenetic and genetic alterations. And there are so many pathways and factors which are responsible, which gives us a potential to manipulate them in a different ways. So we all know these medicines, lenvatinib, cabozantinib, regorafenib, sorafenib. So they block different kind of VEGF inhibitors, PDGFR, alphas, betas, with additional pathways like FGFR, FLT1, FLT3, RET, and sorafenib. We all know RAS-RAF pathway, how it blocks. Then immunotherapy, we all know how it works. So when we talk about the TKIs or the liver cancer treatment, what do we want? What do we expect? Obviously, these are the factors we want. But ideal situation is not there. It was not there. Maybe hope we will get molecules which are easy to use, are patient friendly, and are within the reach. So if we look at the management of unresectable hepatocellular cancer, we have about 7 options or 8 options, out of which 4 are TKIs, which are approved as of today. So first line options include sorafenib and lenvatinib as far as the TKIs goes. In second line, we have regorafenib, cabozantinib, which are there. So these are the guidelines, the version 21.1, which says the preferred is atezo-bev, and other recommended is Sora and lenvatinib, which are class 1 recommendation, but both are to be used for class A child 2 category. In second line, again, the recommendation is for class A only. So talking about sorafenib, we all know, we have all used this medicine, and at times we have felt difficulty in giving it in full doses. Barring very few patients, none of them are able to tolerate in full doses, that we all know and have experienced. So this was the study which was done, the SHARP study was there. So phase 3 study, it was a multi-center randomized double-blind placebo control. Again, pathological analysis was required at that point of time, no previous systemic therapy, not eligible or had disease progression on or after surgical or locoregional therapies. Sorophenic was given at 400 milligram BD compared with placebo. Primary endpoint was OS and secondary was time to tumor progression. So if we look at the results, Sorophenic gave us OS advantage of 10.7 months as compared to 7.9 months, which was achievement in those days. P value was less than 0.001. And 1 year survival was close to 44%. In this study, there was no CRs achieved and hardly any PR, but just borderline significance, but it was able to give sort of stable disease. So these were the pivotal trials which demonstrated benefit with sorafenib in advanced HCC. SHARP and Asia Pacific study, both showing benefit. The consistent results were there across both the, according to the geographic regions also. So same thing in SHARP trial, 10.7 versus 7.9 months and significant p-value. Asia Pacific 6.5 versus 4.2. Again, significant p-value. Again, coming to the toxicity, we all know we have all burnt our hands initially giving the full doses, but now we are smarter and we have better molecules also. We all know hand-foot syndrome is difficult to manage. Then there is diarrhea, nausea, and we all know loss of appetite is there and nausea, which are cumbersome things to treat. So all we know these two problems which are difficult to manage at times. So since this medicine came, so there were various set and trial methods which were applied to see whether any other TKI works in HCC. So in the sequence, we'll see from 2011 till 2017, it was sorafenib versus the lenvatinib, which raised some excitement again. So this study was presented in ASCO 2017. So it was nothing short of a breakthrough at that point of time, which has shown that, oh, this also works. So coming to lenvatinib, so REFLECT was the study. It was a non-inferiority phase 3 study comparing it with sorafenib in unresectable hepatocellular cancer. The patients were randomized in 1:1 form, and the stratification was Asia Pacific versus Western. Again, the same criteria, and the primary endpoint was OS. So we know lenvatinib has a unique mechanism of action. It covers not only VEGFR, it covers the fibroblast growth factor pathway also. So it is extremely effective in inhibiting the tumor angiogenesis. So this particular pathway is considered a critical and important factor in the anti-tumor effect of lenvatinib. So it is, we know this works against FGFR pathway also. So if we look at the outcome, it was non-inferiority study. The median overall survival was 13.6 versus 12.3. Hazard value was 0.92. And median progression-free survival was 7.4 months versus 3.7. And time to tumor progression again was better in the lenvatinib arm. So quickly, if we look at this, so there was almost doubling in PFS and time to tumor progression, and response rates were very good, 9.2 versus 24.1%, which was quite significant. So again, this was viewed both on the basis of RESIST and modified RESIST 1.1. Same thing again, the response rates were better as compared to sorafenib arm, and this study showed, yes, it is effective with good response rates and non-inferior, and the OR response rates of 40.6%, which are quite great and not matched by any other agent at this point of time. So if we look at the taste and the other things, even then the response rates are very good. So it compares favorably in favor of lenvatinib. So, and it is seen if the patients are responding they are having good responses on lenvatinib, their overall survival is further likely to be better as compared to the non-responders. So median outcome, if we look at OS, was 21 months as compared to 17 months. But in patients who were responding, it was even better, 26 months versus 22 months. So same thing again, but we know the side effect profile. This was comparable and better manageable. Only thing different was hypertension and proteinuria, which were there. And we all know now, by now that yes, lenvatinib in terms of tolerance, it is better. So the conclusions from this was, it's a good molecule, and median duration of study treatment was higher with lenvatinib due to better tolerability. So in the second line, the options that we have today is, one is regorafenib, the other is cabozantinib. So resource trial, regorafenib in second line. This was again a phase 3 study, but it compared with the placebo, regorafenib 160 milligram per orally once daily. Again, we know in initial days we had difficulties using this drug. Now with reduce, we know how to titrate and use this medicine better. So OS was 10.6 months as compared to 7.8 months in the placebo arm with significant p-value and hazard ratio of 0.63. Again, if we look at this chart, CR hardly any, PR were there in the second line, and stable disease was quite significant. So this was giving a disease control rate, and when we had nothing, at least regorafenib has shown some light. So same thing, again some responses in the second line also. So this resulted in 38% reduction in risk of death and 54% reduction in risk of progression or death. And disease control rates were quite good, 65.2% versus 36.1%. So looking at the side effects, we all know again the hand-foot syndrome and the diarrhea are difficult things which we get, and quite a number of patients had grade 3 and grade 4 side effects. And again, hypertension was there. So the other thing was the cabozantinib. Celestial trial was there. Randomization was done in 2:1 population. And in this study, the 70% of patients, it was used in second line, and 30% of patients, it was used in the third line setting. And the patient should have either progressed or were intolerant to sorafenib, and it was again compared to placebo. I personally have no experience with this cabozantinib, but the updated results have shown the median OS of 10.2 versus 8 months. So it is again showing some responses, and PFS is definitely better when we compare it with the placebo arm. So again, if we look at in the graphical form, some responses, but stable disease to a considerable extent, it is able to give us a stable disease and good disease control rate. Practically, zero practical experience till now. Again, side effects are there, but we do not still no hands-on experience till now. So we will see in coming days as this product is, this molecule is available now with us. With this, I will stop there. Thank you very much for giving me this opportunity. This was data in brief about the TKIs in upfront and second line setting. Thank you.
Thanks a lot, Dr. Sumit. A very crisp and short, a good presentation. Now I will request Dr. Bharat Vaswani. The sir will speak on systemic therapy for advanced or metastatic hepatocellular carcinoma and the role of upfront immunotherapy. Over to you, Dr. Bharat, please.
Good evening, friends, respected chairperson. Thank you, Sachin. Again, the most important thing, am I audible and are my slides visible?
Yes, go ahead, please.
Yeah, thank you. So the topic that I am discussing today is systemic therapy for advanced metastatic HCC, upfront immunotherapy. If I tell you immunotherapy is a flavor of the season, I will not be wrong. And trust me, when I will be presenting two of my cases, it is a magic. It is nothing but a magic. What I call this is as a lymphoma effect. You can see that, and let me start with few of my cases. We are lucky to have a big liver unit at our hospital under the care of Dr. Dharmesh Kapoor. So we see lot of liver cases. Now see the first case. This was a 53-year-old male presented with abdominal discomfort, loss of weight, loss of appetite. When you look into, I'll go first slide. You can see a liver mass. You can see extensive abdominal lymph nodes. I'll go back. The patient was HBsAg reactive, alpha-fetoprotein was normal. When we did a biopsy, because it was not a clear cut, such an extensive lymph node we could never find. I'll go again forward. There was some degree of ascites also. So when you go back, when we did a biopsy, it came out as lymphocyte-rich hepatocellular cancer. If there is any pathologist here, 1% of patients are lymphocyte-rich hepatocellular, IHC proven. We just did, for our sake, although not required, CPS was 35, beta-catenin negative. This was not a childpox A, but a B with a score of 7, ascites, albumin 3.4, other parameters normal. So there was a debate, should we use it? The point was, this was a patient ideally made for an immunotherapy in the first line. So should you give a single agent immuno or you give it a combination with atezolizumab? But we thought, being such an aggressive disease, let us go ahead with the combination and let us now just see the response. Now this was a patient when we started our atezolizumab compilation. After 6 cycles, there is no liver lesion at all. If you see the extensive lymph nodes, the lymph nodes all have disappeared. There are necrotic lymph nodes present now. There is no ascites. So from a patient which was hardly able to move, is absolutely asymptomatic now with no symptoms at all. Actually, a big case, the patient developed grade 2 hepatitis. Dr. Dharmesh Serenas started on steroid, difficult to taper steroid. Ultimately, we come down to 7.5 mg steroid and continued with our atezolizumab. This patient is absolutely healthy and coming to us from Orissa every 21 days. One more patient. The difficult thing was an old aged patient, not exactly 70-year-old, weakness, easy fatigability, 10 kg weight loss, non-HBS, non-HCV, non-reactive. Now, if you look into CT, a big liver mass, 10 by 7.8 by 7, characteristic arterial hyperenhancement with venous washout. There was one more lesion in segment 2. There was a tumor thrombus. There was abdominal lymph node. Alpha-fetoprotein on day 1, 834, upper GI endoscopy had low-grade varices, which we did a banding and then went ahead. Childpox was A with a bilirubin of 2.3, otherwise albumin normal, PT normal, no ascites and no encephalopathy. You can very well appreciate a liver lesion, you can see iotocaval node, and you can very well see a portal vein thrombus. Same thing, a liver lesion, you can see an abdominal lymph node. Now see the response. Now this is a patient who I met day before yesterday. This is pre-therapy. The mass solid component has entirely disappeared. There is a shrunken, what we say, capsular retraction. The mass size has come down to 34 by 47 by 31 millimeter from an original size of 10 by 7 by 7.5 centimeter. If you look into it, there was an iotocaval lymph node. It has disappeared. Now, these sorts of response was unimaginable. I can imagine you might have some cases. We are trying to prepare our 10 cases and then we'll present it. But you can never imagine such a big abdominal lymph node now completely disappeared, patient healthy within the 4 cycles. If you see the alpha-fetoprotein also, from 825, it came down to 25. So with the positive thing, let me start my presentation. We had 3-4 more cases, but because of shortage of time, I could not present. In 2020, from 2018, as Dr. Sumit presented, the numbers have increased to 34,000. Unfortunately, 33,000 more than they die of this disease. Please understand, 95% mortality in this cancer, and this is because of the late stage of diagnosis. It is 8th highest killer in Indians. We all know the only difference in the epidemiology is we have predominant HBsAg involved HCC as again Western country where it is HCC. Is it important in immunotherapy? The answer is no. Yes, it is important when we give Sorophenic, where in the HBsAg reactive they may not do well. And we have some degree of obesity and metabolic syndrome which may lead to this disease. Now, this has already been presented. What is more important is try to concentrate on the right side of the curve. Whatever advances we are now getting has been immunotherapy single agent, immunotherapy with anti-VEGF, immunotherapy with TKI, or dual IO therapy. So the future of hepatocellular cancer is immunotherapy, and but immunotherapy. Now, when you look into the NCCN guideline, this is old, Atezo-Bev, unless the patient cannot afford, please understand, this is the treatment, go to treatment. And or if the patient has contraindication to immunotherapy, such as post-transplant or autoimmune disease, you should think of giving your Atezo-Bev, or if the patient may not be fit for anti-angiogenic drugs, for example, if the patient has bleeding diastasis, post-surgery, or perforation, you think of a single agent nivolumab. As I'll be telling, although it was not a superiority, but 16-month survival has not been achieved except for immunotherapy or its combination. So definitely the safe option there also. Now, this has already been discussed previously. What is more important is, do I get a better response with immunotherapy and combination with BEV? The answer is yes, 30% versus 24%. But what is more important is why I should use my immunotherapy is because that duration of response is 18 months. So if I am lucky, I have a response with immuno plus BEV, I will be responding for as long as 1.5 years. Here were the studies where 1 year was a luxury, and now you are having a person who is just responding with a single immunotherapy combination for 18 months. I will be telling you in the later part of my presentation. So that thing has changed. Now, if as I am presenting today, there is only one combination which has a phase 3 data, that is Atezo-Bev. But just wait for this year ending. You have 3 blockbuster phase 3 studies which are coming up, which will definitely create a competition in this hepatocellular carcinoma also, as also RCC, where you remember now you have 4 blockbuster combinations. But as of now, on a Monday morning, if I have a patient who is fit enough for everything and who has the resources, I will definitely go ahead with my Atezo-Bev combination. Why should immunotherapy work in HCC? There is a basic principle that HCC develops in an inflammatory milieu. So the most of the times it is post-viral, where there is a prolonged inflammation creating dysplasia and then carcinoma. So the very fact is immunotherapy works better in an inflammatory milieu. There are some indirect evidence to suggest that anti-tumor immunity is definitely a very important thing in HCC. For a post-liver transplant, tumors with a marked T-cell infiltrate and a high CD4 to CD8 ratio have reduced risk of recurrence. Similarly, once you resect your HCC, those tumors with a high activated CD8 positive has improved disease-free survival and OS. So definitely immunotherapy is the most important thing, what we call it, and the thing which will stay in the future in HCC. Let me start with my dual combination and the blockbuster study, probably the most important study in HCC in the year 2020. That was presented in NEJM March. Combination of Atezo plus BEV in unresectable hepatocellular carcinoma. Treatment naive patient with locally advanced child-pox B 15%, BCLC B and BCLC Cs 85% were randomized to Atezo-Bev in the ratio of 2:1 to Sorophenic. This treatment was continued till clinical benefit or unacceptable toxicity. The primary endpoints were overall survival and PFS. Now, probably if you look into your lenvatinib data or others, those were super selective patients where liver involvement should be less than 50, you should not have a main portal vein thrombosis. But if you look into IM Brave 150, this was characteristic of the real world. Asians 40%, BCLC B is around 20%, MVI involvement, macrovascular involvement in around 40%, around 25% had varices, around 50% were HBsAg positive. So what we get in India or in eastern part, probably this was representative in this trial. Most important thing is something that we keep on telling and keep on remembering is you should always do your upper GI endoscopy before you start this combination. And if you have a varices, please treat your varices with bending as we did it in case 2. Second most important thing is if you had a bleeding episode in the 6 months, probably you should avoid this combination. But the most important thing is 2 things. One is upper GI endoscopy. Please do it and clear and band your varices. And second important thing is if there is an active HBsAg infection, you should start treating it with your antiviral before you start with this combination. Now, most important things again. 3 things I'll be telling. First thing is 30% response rate. Remember your Lenva of 24%, your Sorophenic only 2%. But the most important thing, apart from response, is the duration of response. 18.1 months has never been achieved in any of your phase 1 study, phase 2 study, and phase 3 study. So 18 months is probably the longest duration of response in any of the studies in hepatocellular carcinoma. And the third most important thing is 3/4 of the patient will either have a stabilization, a partial response, and a CR. So you have never imagined that 3/4 of your patients who are fit enough for your treatment will have either a stabilization or a PR or CR. This is as good as what we call as chemotherapy, probably better than a lung cancer chemotherapy data also, and probably better than majority of your chemotherapy data in any of the cancer. The progression-free survival. There was a reduction in the risk of progression by 35%. 0.65 is a major number with an absolute benefit of 2.6 months. And when you look, this was updated in S code GI 2021. The final results are also very good. There is an absolute benefit of 5.8 months with a reduction in the risk of death by 34%. As I will be telling you, 19.2 months, in spite only 35% of the patient took second line. So the entire benefit, whatever this 19.2 is majoritarily due to the effects of the immunotherapy, I believe. What about quality of life? If you see your ESMO, so there was a significant delay in the deterioration from 3.6 months to close to 1 year, which was statistically significant. So better, every parameter, it is better than any of the trials. And when you look into the toxicity, the major toxicity grade 3 is hypertension, and you have a lesser number of immune-related side effects. Most important slide again, what toxicity. 23% SAE, serious adverse event. Only 10% of the patient you had withdrawal of both the drugs. Grade 3 or 4 toxicity, 43%, which was in fact lesser than Sorophenic, which was 46%. So all in all, a drug which is safer than Sorophenic with all the parameters which are significantly better, takes that, what we say, the match. If you say a T20, takes away your final things. This is most important for me was that only 36% of the patient in IM Brave 150 took more than one line of therapy. So can you imagine, most of the things people were not able to take, 64% were not able to take much of a therapy after they took a Atezo-Bev. As against Sorophenic, where 26% had immunotherapy, 33% has tyrosine kinase inhibitor. So Sorophenic had worked well because they have taken immunotherapy in the second line and good drugs in the second line, not because Sorophenic was a very good drug. That is most important thing for us to understand. Apart from Atezo-Bev, what all we have to look in the future, and I am thinking we are excited about phase 3. Himalaya study has completed a Curel, which is a combination of durvalumab and tremelimumab. LEAP 2002, which is again a phase 3 study, has completed a Curel for Lenva plus Pembro, and Cabozan and Atezo is fastly recruiting Cosmic 312. But I will like you to just look at the right side of the column because I will be presenting a study 22 and a keynote study for pembrolizumab. This was highly publicized last year by AstraZeneca, combination of durvalumab and tremelimumab. I will like you to concentrate on the one arm only, which is supposed to be probably the arm which will really give you an advantage. Single dose of tremelimumab, 300 mg with durvalumab, only single dose, followed by durvalumab maintenance. See your overall response rate, 24%. Again, an acceptable thing. Grade 3-4 toxicity, 35%. But most important is the OS. So the OS is 18.73 months, as you see here, 18.73 months. So again, a combination which has given you a survival of more than 1.5 years. From 1 year to 15 months to 16 months, the single agent, for all the combination, it is now more than 1.5 years. So this we will be seeing now, because in Himalaya study, which will be published sometime later in the year, a very big study of 1,200 patients, which will be really telling you whether this will compete with the blockbuster Atezo-Bev or not. The second study that also came in ESCO 2020 was a phase 1B, Lenva plus Pembro. This study is important because the N number was close to 100. Again, if you see, overall response rate 36%, biggest till now. Disease control rate of 88%, again the best till now. Median duration of response 1 year. Please understand, this is a phase 1B study, so definitely a study which we will be eagerly awaiting in future. But still, being a phase 1B, let us be bit guarded now. The progression-free survival of 9.3 months and the OS of 22 months. Just try to see, the more you are going ahead, probably that the benchmark that has been created by Atezo-Bev probably may not be crossed, but may be matched by a few of the other drugs that will be that we'll be getting the phase 3 studies in the near future. This is our phase 3 study, LEAP 002. Again, this study is comparing Len Pembro versus Len. Actually, I'll be more interested in knowing about Len also, because most of these people will be taking second line immuno also. So this study will also tell us whether this combination is really going to work and whether they will be really going to compete with our Atezo-Bev combination. This is a study that has been published in ASCO GI last 3 months back, Regorafenib with Pembro. Important thing is most of the studies show that the disease control is as good as 85%. This is an earlier study, but yes, definitely a study which we will see phase 3 data in the future. One more study which was published in ASCO GI last 3 months back was a Tivozanib and Durvalumab. So what you are seeing is now in the future you won't have a single drug, but a combination of either of the 3 combinations that I have discussed till now. What about single agent immunotherapy? Now I lived this study as a way where can I give my patient a single agent immuno? I have 2 patients who are doing well for more than 1 year now with a single agent Nivo, and maybe in some other conference I'll present that. This first line Nivo versus Sorophenic in treatment naive fit patient with Child-Pugh class A. Now, if you see the response rate, it is better than Sorophenic, 15%. I will like you to concentrate on the right side of the curve about this curve. So definitely around 20% of the patient will have a PFS of more than 3 years. Now that is what makes the fun of you are giving a immunotherapy in the first line. If you are lucky enough, 20% of the patient will be progression free at 3 years. You could never imagine that with any of your combination of Sora or Lenvatinib. So for my sake, I think of immunotherapy in all my patients as a single agent or as a dual unless I have a contraindication. Although OS was not statistically significant, but it was 16.4 months. Again, a very big thing from what we have seen before. Toxicity, the least toxicity among all, only 22% grade 3-4 toxicity as against Sorophenic, which was 49%. So a safer drug. So I may use my immunotherapy because I may get a good responses, I may get the least toxicity, and I am particularly interested in my tail of the curve, which is quite one of the best we have seen in the recent past. Of course, with better quality of life. Is there a data of Pembrolizumab as a single in the first line? So again, in this ASCO GI 2021, in the subset of Keynote 224, single agent Pembro gave a OS of 17 months. So either of the two, 16 to 17 months is a benchmark that a single agent immuno will be done with a response rate of close to 18%. So 15 to 20% of the patient will have a good response, but the median survival in those who have a stabilization will be around 1.5 years. The last slide, can I use my immunotherapy in Child-Pugh B? So the answer is big yes. There was a discussion going on in the chat box. There is a data for mu of the drug, but I will be comfortable using my single agent Nivo. ORR of 12.2 versus 15%, disease control rate of 55%. For those patients who are treatment, the OS was 9.5 months as against 7.6 months who had already taken treatment. More importantly, toxicity was manageable. When we give our drugs in Child-Pugh B, what we think is not of efficacy, but of toxicity. And probably I have used in 3 patients and 2 patients are surviving for more than 1 year. They have now gone in decompensation, but thankfully the cancer is controlled. The liver is taking a toll on the health. So for me, in Child-Pugh B, up to score 8 also, I may give my immunotherapy as a single agent. So if I have to summarize my upfront immunotherapy for HCC is here to stay. We know HCC is an immunogenic tumor. The future is IO plus a molecular targeted therapy or a IO or a IO anti-VEGF, because this combination improves responses, PFS, survival, quality of life. Most important thing I tell my people is, please don't wait for your aggressive treatment or the best treatment to start early. Because the earlier you start, the better is the performance status. Mind well, the responses will be excellent. Poor liver function, poor performance status should not be an excuse not to give your immune checkpoint inhibitor. You can give your single agent Nemo up to 8 score also. And last but not the least is, liver cancer is not the field of only hepatologist or a surgeon or a medical oncologist. It is a multidisciplinary team effort where everybody has an equal and an important role. With this positive thing, I stop my presentation. Thank you, organizer, for a patient invite.
Thanks a lot, Dr. Bharat. Very exhaustive and very detailed presentation about the immunotherapy in HCC. It was actually an eye-opener. I haven't actually heard about many of the combinations which you presented. And very detailed case presentations which you have shown has actually opened us the eyes. We hardly see any good CR or very good PR with Sorophenic or any of the other drugs. Now, I will request Dr. Manish Singhal. Dr. Manish is... Hello. Dr. Manish Singhal is a senior medical oncologist in New Delhi, and he will present a talk on systemic therapy for advanced hepatocellular carcinoma. What are the second line and subsequent options? Over to Dr. Manish, please.
Thank you. Am I audible? Am I audible?
Yes, Dr. Manish, you are audible.
But why am I not? Can you view me also?
No.
I don't know what's happening to my camera. Nonetheless, so congratulations, Dr. Bharat. I think it should have been a debate because opposition में Dr. Amol को opposition में रखना चाहिए था because you presented like a debate. You were trying to convince everyone that immunotherapy is the way to treat patients. But nonetheless, so I think it was a great presentation. Good compilation of the entire data set. And so I think my job is already done because the two presentations actually presented almost everything. So is my slide visible to everyone?
Yes, go ahead, please.
Yeah. So I think so the last word on immunotherapy is not yet laid because immunotherapy seems to be working the best along with a TKI. And it is like putting all your eggs in one basket and throwing everything at the patient in the first go. And that is how perhaps the science is moving. The question is, what do you do if you use immunotherapy and TKI upfront, and if the patient doesn't respond, then what are you left with to fall upon? So that's the question. I don't think so. We have a very clear answer of what to treat with these patients who have been exposed to TKI and immunotherapy upfront, and when they progress, then what to fall upon. So I think the Barcelona clinic liver cancer staging is well known to everyone. And we have already seen that there's a lot of crowding on as far as the drug approvals are concerned and the drugs which are available to us once a patient has progressed on the first line therapy. And whatever you use in the second line will depend on what you have used in the first line. And now since the first line treatment has evolved so much, such as the use of Atezo and Bev as one of the frontline drugs, and soon we are going to see further combinations such as the TKI and immunotherapy combinations. Perhaps the second line is likely to evolve further. So whatever we are going to use second line and beyond, perhaps whether there is a role of re-challenging with immunotherapy again at some point in time. So all these are very pertinent questions which I think would be answered as the first line treatment keeps evolving. So as far as the present second line therapy is concerned, there has been a lot of efforts to increase second line therapies. So these are various studies which have been presented, such as the everolimus studies, very similar to what we treat metastatic RCC, the Brevanib study, the Ramucirumab study, and there has been study of beguilated Adriamycin, there has been study of Regorafenib. So all these studies have been there, which have been trying to test patients mainly in childhood class A, and the childhood class B is more or less of B7 up to B7 one can treat, but beyond B7, I think it is it's a clinical call to treat or not to treat, because perhaps the patient is likely to succumb to their liver decomposition rather than succumbing to their liver disease, to their liver cancer. Because whenever you are treating HCC, you're not treating just one disease, you're treating actually two diseases. One is the liver cirrhosis, and on the other side is the liver cancer. And which one is likely to be more concerned in the coming times depends on their Chaipu class. So the studies which have already been discussed by Dr. Sachin as the Celestial study, the REACH2 and the Resource study, which have been tested in the second line. I'll not dwell on them much. But as far as the phase 3 second line therapy trials are concerned, there are various studies which have where median overall survival has been the primary endpoint. And more or less these endpoints have not been met in various studies such as the BRISC, the EVOLVE trials. So everolimus and privarnib did not really make a mark, whereas ramucirumab also did not really make a mark, but it showed that ramucirumab in a pre-planned analysis where alpha-fetoprotein was more than 400, it did show that there was a improvement in overall survival. And since it was a pre-planned analysis, it could actually reach statistical significance, and that is the reason you see that as a category 1 indication for alpha-fetoprotein more than 400 in the NCCN guidelines. So as far as second-line therapies are concerned, the most talked about therapy is nivolumab. Mind you, all these therapies have not really been tested. All immunotherapy trials have never been tested in a phase 3 setting. These are all these studies were phase 2 settings, and they got an FDA approval, but they are still not considered category 1 in the NCCN guidelines. So if I were to discuss the Checkmate 40 study, which has already been discussed upon, it was tested in advanced HCC with progression on 1 prior line of therapy for patients who were not candidates for TK, and there was a dose expansion and a dose escalation phase, and the final dose was 3 milligram per kg as is used mostly, and the overall response rate was the primary endpoint. The study did show that the overall response rate is around 20%, so the ballpark is about 15 to 20%, with the median overall survival reaching almost 15.6 months in the second line, which is quite heartening to see, because the median overall survival that we have witnessed so far with sorafenib or with lenvatinib is about a year or so. So in second line, about 15.6 months was something which is considered quite reconciling. And the overall survival in the first line was 28.6 months, but that was a very small subset of patients. The pembrolizumab 224 study was also there, and it showed an overall response rate, again, to the ballpark figure of around 20% or so, with very little CRs, but mostly PRs, and the adverse event profile was also quite similar. As far as anti-angiogenic agents are concerned, ramucirumab is the only agent which actually stood the test of time, and we'll discuss about that option. I don't think so that many people use that as one of the options. So the resource trial is the regorafenib study, which is the second line, I think already discussed by Dr. Sachin, Dr. Sumit Goyal. And so this study was a phase 3 study of regorafenib. The tolerance was not very good. And if you look at the overall survival, which was the primary endpoint, it did show that it increased to 10.6 months versus 7.8 months. And if you look at the forest plots, I think the progression-free survival and overall survival were all subset analysis were favoring the use of regorafenib. What is more interesting to see is that the quality of life indexes of regorafenib actually did show worsening of quality of life with the regorafenib as compared to the placebo arm. The scores were lower in regorafenib group throughout. All the scores were actually lower. And we know that regorafenib is not an easy drug to tolerate. And mostly patients have to go down on their doses to 120 or maybe 80 milligram per day instead of 160 milligram per day, 3 weeks on, 1 week off. Although the overall survival in the exploratory analysis was reaching almost 26 months, but that was only in patients who with outcomes with sorafenib followed by regorafenib. So if you combine the two, the overall survival was reaching almost 26 months from the time of their diagnosis, not from the time of when they started off regorafenib. So coming to ramucirumab, ramucirumab was a multi-center randomized double-blind study, which was a placebo-controlled study, and it was after failure on sorafenib. And it had a pre-planned analysis to look at patients who had more than alpha-fetoprotein or more than 400. And the study primary endpoint was overall survival. It didn't meet the primary endpoint because it was not reaching statistical significance. But those patients who had alpha-fetoprotein or more than 400, it did reach statistical significance. So this particular trial actually got ramucirumab approval in patients who had alpha-fetoprotein of more than 400. Cabozantinib, already the study has been discussed by Dr. Sumit earlier. It was again a 1:1 randomization to cabozantinib versus placebo with primary endpoint of overall survival. The study again met its primary endpoint, and the cabozantinib was around 10.2 months, which is very similar to what we have achieved with regorafenib versus 8 months in the placebo arm. The progression-free survival was improved to 5.2 months versus 1.9 months. And again, the drug is not very easy to tolerate, and it does cause a lot of palmoplantar erythrodysesthesia, hypertension, and sometimes liver dysfunctions. Nivo-EP is one combination which has been looked upon, and there are various combinations of Nivo-EP with different dose profiles of Nivo-EP. Nivo being 1 milligram per kg versus EP being 3 milligram per kg, or Nivo 3 and EP1. Of these profile of various combinations, the Nivo-EP with higher dose of EP actually led to the best median overall survival. And of course, those patients who achieve a CR, PR had the highest survival. But the toxicity is also quite exponentially raised because of higher dose of ipilimumab, which is used. And that is the reason that the durvalumab and tremelimumab combination was actually brought in to see whether this combination is doing the trick or not. So definitely it highlights one very important thing, that HCC is an immunogenic tumor, and the immunotherapy can be exploited to result into some overall survival benefit in this particular disease. There's also one good theory that that there can be a synergistic effect between using a PD-1 or a PD-L1 blocker and lenvatinib. We know that there is a Wnt signaling pathway, and this Wnt signaling pathway may act with the FGFR pathway, and lenvatinib is an FGFR inhibitor, and therefore there is some sort of synergistic effect happening with PD-1 or a PD-L1 blocker and lenvatinib, and that is the reason it has been seen that those patients who have been exposed to immunotherapy, they can be re-challenged with lenvatinib, and some responses can be brought in. So this is an exploratory analysis of lenvatinib being used after unresectable, after the patients who have failed PD-1, PD-L1 blocker, and it's shown that the median progression-free survival can be around 10.3 months, with the median overall survival almost sitting at 15.8 months. So these patients would have received atezobev and then can go on to receive lenvatinib. So this is how the likelihood of how these newer agents can be used after they have been exposed to the type of agent that they have been exposed in the first line. So if you go by the guidelines, the NCCN guidelines, it is only regorafenib, cabozantinib, and ramucirumab, which is labeled as category 1. Nivo and Pembro or Nivo-EP are not labeled as category 1, they are category 2A, because all these agents have not passed through the rigors of a phase 3 trial, and they have all got approval based only on a phase 2 studies. Well, we know that the field is evolving a lot, and with this, I'll just conclude that the first line treatment is evolving, and that is how we are likely to decide on what we are likely to use in second or third line or lines beyond. So as the first line space evolves, perhaps that will define what is to be used in the second or lines beyond that. As far as the current status is concerned, the agent which are approved are regorafenib, cabozantinib, ramucirumab, and of course, if immunotherapy has not been used upfront, that can be used in the second line. And nivolumab seems to be the favored drug by most clinicians, and as per the data that goes. That, thank you, and I'll stop sharing my slides and back to the organizers.
Thanks a lot, Dr. Manish. Now, because of the shortage of the time, we will go directly to our panel discussion. May I request Dr. T. Raja, who is the Senior Medical Oncologist at Apollo Institute, Chennai.
Good evening, everyone. Dr. Sachin, Dr. Gautam, thank you for inviting me. Hope I am visible, audible.
Yep. Yes.
Thank you. Excellent talks. At least I could join for the second of it, and the immunotherapies and money single stock. Excellent talks. And I'll move on to my panelists. I have very excellent panelists with me. and we'll try to see how to critically look at all the three speakers data set that are presented and how practical we are in trying to approach. Some of these are really convincing data, blockbuster data, totally agreed. But then how much do we practically take it forward, and how well they are applicable in our sector. Dr. Kripa Shankar, if you are there, I'll begin with you.
Sure, sir. Hi, sir.
Hi, Kripa. Modified Bclc staging system. So, do you think this is the best way today to decide on which patients you want to choose systemic therapy? And this is handy, this is good, and this is advantageous, or does this has any handicap?
So, yes, sir. So there, apart from the BCLC, we have other staging systems as well, the Japanese staging system, so many other staging systems as well. But I think the BCLC has been used a lot in practice as well, because I think that's something which is far more easily reproducible and something which is actually usable in clinical practice as well, sir. So I would definitely use it as a guide to, choose my systemic therapy based on. Somebody with BCLCC, like you rightly shown up, would probably be an ideal candidate for systemic therapy. A and B would probably where I would be looking at doing local therapies as well. So definitely, yes, sir. I would definitely look at using the BCLC as a guide in clinical practice.
So what is the biggest difference as far as you are concerned between the BCLC and very, very commonly used the child book class? They are exactly not the same. One is quantity, the other one is quality of liver. Can I say that way, or they are interchangeably used? It is overshadowed. What is your take, Dr. Kripash?
Yes. So the child puke is basically an assessment of your liver function, sir. Basically, it tells us whether, if somebody falls into child puke A is where we have most of the data, and B only up to B7. Beyond that, we don't have the data as actually to use any of these drugs, the approved currently drugs. So I would use that to assess the patients. Like, for example, somebody with cirrhosis would really be useful for me to use the child puke score to assess the severity of cirrhosis and the liver function as well. So that's where I would look at it. But as far as HCC is concerned, I would definitely look at using the BCLC much more rather than the child puke as well, sir, because that would be a broader way of looking at it. And the child puke probably to assess the liver function or the severity of cirrhosis as well would how I would look at it, sir, along with the MELD score, the model for end-stage liver disease as well.
Perfect. So one is both are not exclusive. Both are handy in some way or other. Intelligent to use both. Is that right, Kripa? What you said?
Absolutely, sir. Absolutely.
So now we'll move on to the our conventional treatment options. They have stood the test of time. So I don't think we can look down upon them, even though Bharat really blasted them out of the park actually. But let's give it a little fair share of their glory. Dr. Kunal Jain. The sorafenib data, that really convinced us that systemic therapy does work in hepatocellular carcinoma. And I am showing the overall survival from the SHARP trial. And I am also showing the primary endpoint and the secondary, some of the secondary endpoints. And 10.7 months versus 7.9 months. Even though the other endpoints like the time to symptomatic progression was not changed, but there were some other subtle and secondary endpoints like median time to radiological progression, so on and so forth, which was clearly superior. So do you think, Dr. Kunal, that sorafenib is done and dusted, or still one of the bread and butter drug for you?
Not really. I would not completely write it off in our setup, given mainly the cost constraints. But at the same time, I would say, I think with the availability of generic lenvatinib, more share of sorafenib patients are now moving to lenvatinib purely because of better tolerance. Because majority of the patients, at least 9, maybe 8 out of 10 or 9 out of 10 in our setup are not able to tolerate the full dose of sorafenib, recommended dose.
Perfect. So now, Dr. Jatin, if you're there, do
yes,
you think, of course, lenvatinib will come to that in a minute, but this is an important data set that was presented by the Chinese group Cheng, which showed that Asian, non-Asian, hepatitis B, hepatitis C. This is something important when we try and choose sorafenib. What is your interpretation, Dr. Jatin?
Well, there are always racial differences between the TKI's usage, and sorafenib has always stood the test of the time. I simply cannot write it off because still a major chunk of population takes sorafenib, and it is a drug in which can be used in childhood B also. And if you compare lenvatinib, the data is mainly in childhood A, but if you use lenvatinib in childhood B, there is some dent done, but actually it is lesser than sorafenib. So strangely, so yes, looking at this, it looks pretty strange. It doesn't perform well in hepatitis B in Asia. It's really bad. And there are more chunk of cases, unfortunately, of hepatitis B in Asia. But in hepatitis C, it is a good drug. I mean, we have also seen the results really well.
Perfect. Thank you. That's where the data as it stands. Dr. Vivek Agarwal, none of them then later on improved upon what sorafenib could achieve until lenvatinib arrived. And so lenvatinib, as we just heard, conveniently is also generically also available. That's one another big advantage. So lenvatinib, this is the median overall survival, which is very identical with sorafenib, but of course a superior PFS, but the overall response rate is superior, and this is where it really takes the cake. So Dr. Vivek, what is your take on lenvatinib and how aggressive you are in converting all your so-called sorafenib patients into lenvatinib patients?
Sir, I think Vivek has not joined.
Can I take this question to Dr. Lalit? Lalit is there?
Dr. Lalit, no sir, he is also excused. I think Dr. Amol is there.
Dr. Amol, yes, of course.
Yeah.
Dr. Amol, I'm trying to ask between now lenvatinib convincing data, you have switched completely, or what is your take on lenvatinib?
Yeah, am I audible? Yeah.
Yes, Dr. Amol.
Yeah, so of course, lenvatinib is an easier to handle drug as compared to sorafenib. And sorafenib, of course, is a difficult drug, especially at the full dose. But if you are able to titrate the dose as per the patient's side effect profile, it is not a bad drug. But yes, now that the generics of lenvatinib are available, we try to start lenvatinib instead of sorafenib, or we try to switch those who are on sorafenib into lenvatinib. So yes, it is an advantageous that especially lenvatinib generics are there, and it is slightly less toxic as compared to sorafenib. So yes, it's a good drug to have.
Okay. So Dr. Bhuvan, are you there, Dr. Bhuvan?
Yes, sir. Yes, sir.
Hi, Dr. Bhuvan. So I've just enumerated the differences between sorafenib and lenvatinib. From selection point of view, I've tried to emphasize the use of sorafenib in a lot of data in the real world. We have got 10 years experience, and even in child books B, it can still sell. So what is your take?
So frankly, I think since the time it has become generic, it has become so easy to use lenvatinib over sorafenib. Okay. And I think going with our practical experience, rarely, if any, you see a metastatic HCC who's physically fit to receive sorafenib in today's world. I think lenvatinib, you start with 8 mg and then you increase it to 12 mg if body weight is more than 60, is usually the way to go for a patient, if he fits the criteria for a TKI. And probably in my clinical practice, almost all the patients I prescribe lenvatinib. I find personally, I find no reason to give sorafenib, especially with generic becoming available.
Excellent. That's a blockbuster statement, that no reason to prescribe sorafenib. So let's leave it to the others to contend it a little later. But that's one way of putting it across. No problem. You are not deterred by no data on child books B and all that, and you would expand your indications, Bhuvan, even then with lenvatinib.
So as I said, patients don't read textbook and come. But then if I have to if I have to give a child poop late B or C tablet, I might give lenvatinib over sorafenib. I mean, that's where I'm coming from. So the tolerance is much better. I think the only adverse effect which we come across is hypertension, and I think that's fairly well controlled. So,
interesting. Agreed. Okay. So now we will go into the immunotherapy domain, and Dr. Kripashakar, once again, we will talk a little bit about single agents, nivolumab versus sorafenib, and this is the OAS and PFS data of Checkmate 459, and this has been well presented, but a median overall survival of 16.4 months versus 14. What is your take on nivolumab, Dr. Kripashakar?
So as you've rightly shown the data here, sir, this unfortunately was a negative study and could not show superiority over sorafenib again. So again, probably if I were to, I would probably go with the IMBRAVE 150 data set, which we're using atezolizumab plus bevacizumab actually showed a statistically significant improvement in overall survival. It was 19 versus 13 months. So if at all I were to choose immunotherapy in the first line, I would probably choose a combination of atezolizumab plus bevacizumab over just single agent nivolumab. Because, I mean, like, unfortunately, like I said earlier, this was a negative study, sir.
We'll come to that in a minute. But I just want to also present the ASCO GI 2021 update. I mean, as was already presented by our previous speakers. And this is pembrolizumab monotherapy in Keynote 224. Dr. Kunal, this was presented a couple of months ago, and I'm just capturing the essentials. The ORR and the duration of response is captured here, and a very impressive kind of a 30% tumor reduction, so on and so forth. And the PFS, time to progression, and the overall survival for pembrolizumab single agent, first line. So, Dr. Kunal, your comments. Dr. Kunal is there with us.
Kunal, unmute yourself. You are muted.
Yeah. Phase 2 study, but kind of showing the similar results as were with nivolumab, with the similar kind of overall survival and in terms of response rates. So again, choosing between the two, I think majority of us, because of the patient assistance that we get with nivolumab, will probably go with nivolumab. But I don't think there is, in terms of data, probably both are the same. The only advantage of nivo, other than the cost, will be use in child's Book B as well.
Okay. So, Dr. Jatin, IMBRAVE 150, much alluded to the data, and the impressive overall survival and the PFS that was presented in the ESMO late 2019, and then appeared in publications last year, and also was updated at the ASCO last year. Dr. Jatin, how practical?
Practically in our setup, I think only 1 to 2% of, frankly speaking, patients are able to. One is the cost constraint, and second is the varices part. I mean, we have to be really careful in using this particular combination in gastric varices, because despite banding and all, we have seen in some, although I don't have much experience of using this, but the data is fantastic. Yes, if someone is having a good performance status, child Book A, affording, I would definitely go with this combination.
Okay. Dr. Amol, there are some contenders, as was presented earlier, the doublet of durvalumab plus tremelimumab, and we have the lenvatinib plus LEAP-002, and how significant these you expect as a contender to the IMBRAVE 150, Dr. Amol.
As far as the IO trials in hepatocellular carcinoma is concerned, both the Nivo and the Pembro trials initially were reported as a PFS benefit, but later on end up showing no OS advantage. And IamBrave is the only one which in this update also is able to show OS advantage. So as far as the newer combination of the Himalaya trial is concerned, we need to wait for the data to come up, especially the mature data of OS, to have any suggestion that it will really make a difference in the practice. I still feel that instead of 2 IO drugs is 1 IO plus TKI or IO plus the VGF inhibitor probably is the way to go. And that is why the IamBrave trial is positive where all other IO trials have failed. So I'm not too hopeful about the other combinations, but atezolizumab plus Bev, if patient is affording and it comes into class A and has no varices, which is very rare to have such kind of a fit patient. But if it is there, then it should be offered. Rest of the IO combinations probably should be kept for second line.
That's a good point, Dr. Bhuvan. Dr. Amol said a very, kind of impressive statement saying that none of the IOs except the IamBrave. That's because of the combo. So, is it because of the VEGF inhibition there that the Atezo has done something, Bhuvan? What do you think?
I firstly think that I think he's partially right that we have had evidence of VEGF inhibitors being beneficial in HCC, be it regorafenib in the second line, and that's I think that was probably the basis that you could combine a IO, which is in an immune tumor such as HCC. You would combine an IO with a VEGF, and I think same is being done with the with lenvatinib and pembro, as in there's some part of it there also. And so I have tried using Atezo Bev. I think the only challenge, I think the good part about Atezo is the support they provide. I think the Roche is among the best in the companies to provide the support. You buy one and you get 2 free, and then I think you give 3 doses and fairly you are at the end of 3 doses you know whether you can continue that or not. So I think that's where the thing has come from. So as rightly said, the only problem with Lenva Pembro would be I think it's off the scientific discussion, but MSD, when you compare MSD with the Roche as compared to PAP support is concerned, it's entirely different. The two companies are entirely different in the way they approve drugs in India, plus the way they market drugs in India. I think all of us have experience of Atezo being much more patient pocket friendly, not patient friendly, pocket friendly compared to Pembro is where I'm coming.
Yeah, I think even though it was really out of the academic, but I still let you talk because that's an important patient implications. Whether I agree or not, you are representing, but that's very important. Finally, the patient pocket, everything is important, and definitely your dinner and drink today is assured Roche is sponsoring it.
No, sir, it's not that. It's that.
Okay.
I have this basic cracks again. So I am I think Pembro works amazing. When it works, it works.
This is the forum. This is our forum. You have to speak. Totally agree that. I'm with you. No problem. So, Dr. Kripa, conceptual question. So the immunos are not doing the job. That's what some of the panelists have said. It is the partner that is doing something more. What do you think, Dr. Kripa, is happening?
So definitely, yes, sir. I would probably agree. As we have seen, even with RCC as well in the first line, where combinations are actually ruling the roost now. You're talking about an IO-TKI combination, and VEGF inhibition has always been one of those key cornerstones of management as far as HCC is concerned, which is why probably you're getting to see the response rates are also much better with a combination of IO-TKI, or for that matter, even with IO plus a VEGF inhibitor, as we have seen with the atezolizumab plus Bev combination. I'm really excited about the Pembro plus lenvatinib as well, because I think that will also be another game changer.
Sure, you're right. It's just around the corner. Now, since we have to cover some of the second line options, regorafenib. So as was mentioned by, I think, Amol and Bhuvan, that this is the key. Why regorafenib would work later on is because of there are so many other factors. The IGF, FGF, and regorafenib has got a pan inhibition. These are all the key that makes this drug important in the second line. And in the second line, therefore, can we say that regorafenib is kind of the standard of choice, Dr. Kunal?
Again, I think majority of the patients, by the time they are for second line, they will not be in child's book A, especially at least what we see. But yes, this is one of the options. But I think second line immunotherapy, if somebody can afford, I would probably prefer, if somebody has received a TKI upfront, then second line immunotherapy for that patient over regorafenib. It's not an easy drug to tolerate.
So, Dr. Jatin, what about cabozantinib? Do you have any experience on cabozantinib in the second line setting?
No, sir, I don't have any experience, but I agree with my previous speaker. In second line is the place where immunotherapies have a very wonderful role to play. I mean, they are very well tolerated drugs. And Nivo can be given in B7 also. So, but cabozantinib is a drug which is coming along, like regorafenib. And the interesting part was regorafenib was given in those who could tolerate sorafenib. So, how cabozantinib will be placed, I don't know.
Cabozantinib is an important drug. Availability is not there. I have used it on.
Yeah.
But
very good
availability is the issue. I agree. So,
yeah.
Any comment on Dr. Bhuvan on ramucirumab? Has it got any role?
Two comments to make. So first about Regora, I don't know. So there are patients who tolerate Regora and they have a wonderful stable disease with it. So I've had these even in colorectal and hepatocellular. I've had these patients who only a few who were able to tolerate Regora and also have a good stable disease going on for almost 4-6 months. And that's what you expect Regora to do. 6-8 months is what maximum will do. And second thing about ramucirumab, sir, I personally feel again if I have to spend that much cost,
okay,
I would rather use a IO rather than Remu. Is where I'm.
So I get the message. They are also not good supporters. I get the message.
It's not, and the cost. These are all costly drugs. So okay, give me your answer. Would you choose Remu or would you choose IO?
I calculate, tell the patient that's the cost. What you were totally agreed with you. I mean, I'm with you on this, but I try to also call the higher ups in that company and say that from tomorrow onwards, don't come and see me and all that. So I try to do all that. So finally, to reach the goal, what you're trying to say, Dr. Amol, second line immunotherapy. You heard, Dr. Jatin saying. And second line immunotherapy, single agent or double agent. But one of the worries about immunotherapy getting used after a TKI, there has been always a worry as far as the lung cancer goes. Why is that we are not concerned about that kind of a phenomenon post TKI use of immunotherapy in HCC or for that matter in RCC also? Dr. Amol.
The second line therapy on an HCC is the thing that no medical oncologist likes to treat, because by the time patient has reached to second line, he has progressed from child's book A to most of the time B or sometimes C. Okay. Second, patient has already financially drained out because if someone has used IO in the first line. Third option is that because we don't have so many options in the second line, it is like poor man has no choice. Whatever that has not been used in first line has to be used in second line. Unlike in lung cancer, we have a lot of options. Especially, we still have an option of cytotoxic chemotherapy in lung cancer. We have to understand in HCC, we are totally forgetting cytotoxic chemotherapy. And because, of course, the poor general condition of the patient, and most of the time have child's book B, where it is very difficult to give cytotoxic chemotherapy. So, unfortunately, in second line HCC, it is we have limited choice. Whatever that is not used in first line, you have to try in second line and see if it works. And sometimes IO do work in the second line. I have used IO in second line HCC, and few of the patient it has shown some response for some months.
Okay, point taken. Even though I did present the data of single agent pembrolizumab, but this, for the sake of completion, we'll move on. Provocative. Kripa Shankar, why forget the chemo completely? Do you think any role, or are we completely leaving that portfolio? Folfox, doxorubicin, and I'm showing something you might have already gone through. This is an anti-arginine approach an ADA PEG-20, and this was, essentially a work from the Memorial Sloan Kettering Ghazan Abu Alfa's group. And look at this particular picture, Folfox plus ADPEG-20, that's an arginine inhibitor. Look at the responses that he has shown. So are we forgetting this portfolio, chemo plus these kind of combos, Dr. Kripashan?
So yes, sir. I think historically, yes, that's how we've looked at it. Because right now we have a host of other options actually to choose from, which we didn't have access to earlier, sir. Earlier we had only chemotherapy to choose from. Now we have targeted therapies, immunotherapies. So we have a whole host of other options to choose from. If I recall right, sir, there's another study from MD Anderson Cancer Center where they've looked at a regimen called PF, which is platinum, interferon, adriamycin, and 5-FU as well.
Right. Yes.
Exactly, sir. So I mean, like, I think we've come a long way from there. And like you rightly pointed out, the mitochondrial inhibitors like ADPEG-20, which is an example or a class in example, that's probably, something for the future. But as of right now, I think we still have a long way to go before that actually comes into clinical practice, sir. So I think for right now, chemotherapy definitely not among the top options for HCC, sir. Definitely with rely on targeted therapies, immunotherapies. I think that would be a combination of IOTK would probably be the way to go.
Yeah. Another issue that I wanted to ask is, how aggressive are we in combining systemic therapy with the loco-regional approach? This is some examples. I mean, I'm sure you always get a call from your interventional radiologist, or and then you say that whether we can combo this, your TKIs with local, and this is the CIRSPS with a systemic agent, and also even the immunotherapy with loco-regional. Hepatocellular carcinoma, unlike some other disease, is still a lot of loco-regional interplay. How comfortable you are all in doing that, Kunal?
I must admit that not using combination approach of loco-regional therapy with systemic therapy.
Dr. Jatin, sir?
Well, I feel that these combination result modality, I mean, combining the loco-regional therapy with either a TKI and IO is a very wonderful way of increasing the survival in this thing, and they should be explored further. And Tactics was a very good study. The thing is, it can be easily practiced where most of the modalities are available in a center, and I really agree that it's a teamwork in HCC, and they should be more and more explored. I am for it.
Thank you, sir. Bhuvan, Inivo plus.
So I am all for a combination of a local plus systemic, but I think there is a very fine line between when it should be done and when it should not be done. And I think most of us, we tend to, so probably when it comes to local therapy, there is, there was this lecture which I had attended a panel discussion, which people were clear that this is for us, a single large lesion, you may still, or you may. So what I would want to do is I would want to sit down with my interventional radiologist and ask him in a very honest way, do you think it's going to work in
teamwork?
So there has to be a very frank discussion, because these are not cheap. A tear cost you around 12 lakhs. And you sit with the patient, and anyway I'm going to give a lenvatinib after that, right? So, or a IO after that. Yeah. So I would want to have a very frank discussion whether how much is going to work. How much is the portal vein function has to be there? How much, the bilirubin, how much liver derangement can they still take acceptance? So I think all these issues have to be discussed threadbare.
Perfect. Thank you. Organizers, I have only 2 more minutes. Don't worry, I'll finish off. Amol, Dr. Amol, all these exciting newer options, vaccines, your take before we kind of sign off with the organizers.
The newer things, I'm not so sure whether they will be working, but probably, of course, another 3-4 years, we may have some data as far as the vaccines and newer things are concerned. But HCC is a difficult tumor, and probably it will remain difficult for another 7-8 years at least.
So even though some initial success, even though some so-called blockbuster definitions, I don't think we have completely conquered this disease. And second, already I think I heard one of our second line is already a nightmare. So I don't think we are still done yet with this. And Kripa, are we winning HCC or it is still even Stevens? What do you think, Dr. Kripa?
I think ultimately the disease is having the final say and the last laugh as well, sir. Because I think we're yet to see a survival go beyond 1.5 years. Because even with the best combination up front, we're only reaching a median OS of around 19 months. And that's based on the IMBRAVE data that I'm again referring to. So I think we've failed to improve beyond that.
If somebody fails on IMBRAVE 150, what to do next?
Sir, the way I would look at sequencing, my options in the second line would be based on obviously the choice of first line. If somebody's got Atiso plus Bev in the first line, then I would be tempted to use cabozantinib in the second line, because that's one drug which has got a slightly different mechanism of action, because it acts on the MET and RET as well. It's a multikinase inhibitor just like the other drugs, but then it acts on the MET. So that would be my choice. And if somebody has got a high IFP of more than 400, I'd be tempted to use ramucirumab in those patients, even if they have failed on Atiso plus Bev. Because just like how we have the data in colon cancer where patients who fail on Bev, ramucirumab is an option in those patients as well. So just an extrapolation, we don't have the data in second line post Atiso Bev. What should we actually do? So, but this is how I would do. My working algorithm would be this way, sir. Because let's remember, at the end of the day, only around less than 10% of patients with HCC actually go on to receive second line systemic therapy, sir. Most of the times they don't go on to receive second line.
No, totally agreed. I mean, already, unfortunately, I latched on to the early data of IMBRAVE 150, and I had started on October, November 2019, 1.5 years on the doublet. Now the patient has progressed, and I'm really facing the question, what do I do next? I think good summary. As you rightly said, HCC is still a long way to go. So I was very, very happy to be with you all. I learned a lot from all of you. It was an honor to moderate all of you. Wonderful opportunity. Thank you, organizers. Panelists, we all thank the organizers. Thank you.
Thank you, sir.
Thank you, sir. Thanks a lot.
Thank you, sir, for an excellent panel discussion. As always, you do justice to the subject you have been given. And thank you all my panelists. And thank you, chairpersons, for the session. And now I have his esteemed guest, Dr. Ved is here to summarize and give his expert comments and his views on systemic treatment of advanced hepatocellular carcinoma. Over to you, sir.
Good evening, everyone. And at the very outset, I thank and congratulate Sachin for this wonderful activity. It's been almost like a feast, end to end, and all topics discussed in one session. I think that's astounding. That's really awesome. There was a comment by Dr. Raja, and he asked Dr. Kripa that are we winning this battle? I think my answer to that would be that we have just started engaging hepatocellular carcinoma. There is still a great degree of nihilism because the responses are not high. The durability of the responses is a question. And what do you do in the second line? And a lot of these patients will be two diseases in one. The liver is unwell and there is a tumor within that unwell organ. And therefore that brings in a huge challenge in terms of the multidisciplinary approach. It's a perfect example, nothing better than hepatocellular carcinoma, where close to a dozen different specialties would collaborate at one point or the other, beginning with the diagnosis, radiology, interventional radiologists, medical radiation, everybody, coming in together, not to forget the hepatologists, the transplant surgeons, and everyone. So this indeed is a prime example of an MDT approach. And all these cases must go to an MDT sort of a setting or a discussion sometime during the course of the treatment. The expanding options in the treatment, as we heard, the TKIs, IOs, VEGF-driven, SBRT, LDT, the liver-directed therapies, all of them are actually expanding the horizon, bringing in more options, and hopefully in the years to come, integration of these specialties, these modalities with each other, the right sequencing, the right combo would give us the desired results. And challenges still remain. We know that even after resection and even after ablation, majority patients would come back. Drug resistance is a problem. surveillance of those who have been treated for future tumors or future complications, long-term, that remains a problem. But still, I think the biggest gain of the last about a decade is the expanding horizon, better understanding of the biology, more drugs, and the medical oncologists getting a foothold. They just put their foot into the door and they opened it with Sorophenic, the short trial. But then the door has gotten open, wide open to them, and then the options have expanded. I think with that, I close this conversation here. And thank you, Sachin, once again. Congratulations to the entire team and all the participants and those who led to the real success of this program. Thank you so much.
Thanks a lot, sir. Thank you. Thank you, Dr. Raja, as well. And thank you, Tarun and his team for helping us in organizing this. And of course, the pharma industry for their support. So